all the way down that tube, which is our esophagus, okay, down to the stomach, all right, to the small intestine and the large intestine, and then through the rectum and out the anus, okay? These are the organs that we are going to be talking about related to GI, okay? The other organs like your pancreas, your gallbladder, and your liver, that's going to come with hepatic biliary, okay? All right, so let's think about that, okay? Does your GI system have its own nervous system? Yes, it does. Yes, it does. It has its own nervous system. It's called the intrinsic nervous system, okay? And why is this nervous system important? Because it's actually what regulates the motility, which was doing, what's motility going to mean? Moving things forward, right? Okay, it's going to regulate moving things forward, along with the secretion of a lot of different types of acids and stuff we're going to talk about along the GI tract, okay? It doesn't need the central nervous system for this to function, okay? Now, where the central nervous system comes in and the autonomic nervous system, remember how we talked about the fight or flight with the sympathetic nervous system? What happens in the fight or flight? When your body goes in the fight or flight mode in your sympathetic nervous system, what happens to heart rate?
Increases.
Heart rate goes up, okay? All right, heart rate's going to go up. Are your blood vessels going to constrict down? Blood vessels are going to constrict down, okay, to try to kind of force some blood flow, okay? Well, that doesn't help the GI tract, because when the sympathetic nervous system kicks in that fight or flight, we're not going to have good motility, but guess what's going to happen? It's going to constrict down on the GI blood vessels. So remember how we talked about the pecking order for blood supply? The GI tract's kind of where? Kind of that middle range. Remember how we talked about that? So when you don't have good cardiac output, remember how we talked about how when you get hypoactive vowel sounds because you don't have good cardiac output? Why is that? Because the GI tract's not getting what? Not getting any blood supply, right? Okay, because it's operating off of this sympathetic nervous system, okay? Now the parasympathetic nervous system comes in and helps us because it will stimulate motility and keep things going forward. It does help increase those secretions that we need so much. But the other thing is you guys have heard of the vagus nerve? What's the vagus nerve going to do? What's the most common thing that the vagus nerve is responsible? What does it do? When you think about the vagus nerve, what happens? What, you've heard people have vagal down. What happens? They syncopate. They fall out on the commode, right? You ever have people say, I passed out on the commode? Well, what happened? They stimulate the vagus nerve, and what do you think the vagus nerve did? Dropped what? Dropped the heart rate and blood pressure out, right? That's why they passed out, right? Okay? Well, that's because that's where that vagus nerve lies, okay? It's within that GI tract. So when they're in there and they're pushing really hard, and they stimulate that vagus nerve, all right, it's going to drop their heart rate and their blood pressure, and that's when they pass out on the toilet. In fact, a lot of times, old school, when we had patients come in a rhythm that was called SVT, meaning that their heart was beating really fast, like 160, 180, we would try telling them to bear down to lower the heart rate. Okay, we would have them call it bear down. Basically, they bear down like they were having a bowel movement to try to lower their heart rate, because what am I trying to stimulate? The vagus nerve. Absolutely. Okay? All right, our GI tract has its own blood supply. Okay? About 25% of our cardiac output goes to the GI tract, okay? And it's going to increase significantly when we eat because it's going to take more work. It needs more blood supply because it's got to do more work. So is that very important when you don't have good cardiac output? Because what's not going to get it? GI tract's not going to get the 25% it needs, right? Okay, so let's think about that. Low cardiac output, low blood supply to the GI tract, okay? So what do you think is going to happen? What's the worst thing that could happen when the GI tract's not working? Oh, there we go. Okay, so we got decreased GI motility, right? Okay, and things aren't moving forward, so what are they going to do? They're going to stand still or backing up, which is going to cause things like bowel obstructions, right? Okay, so when we don't have good blood supply going, we get bowel obstruction, which can also lead to bowel ischemia. Okay, what is ischemia going to mean? Without oxygen, without blood, right? What do you think happens to the bowel if it's not getting good blood supply? It's going to die. Is it going to, can I get that, can go back to working again? Dead bowel is dead bowel. And we got to go in and resect it and move it, right? Okay? So we talked about bowel obstruction. Well, what's the worst thing that can happen from a bowel obstruction? What's going to happen? It's going to perforate and rupture, right? So perf valve, right? That will kill somebody pretty fast, okay? So knowing that we've got blood, our gut has to have good blood supply is very important. We have our own veins and we have our own arteries. We have all kinds of arteries that run down through the GI tract, okay? You don't have to know all these. I don't want you to know all these, but I do want you to know that there's some very big arteries that kind of run down through there, and that if something happens and one of those is severed, your patient will hemorrhage, okay? All right, so we got a couple of functions of the GI tract. Digestion is kind of the big one, okay? All right, this is where we get the breakdown of that food that we eat. Now, do you think when you go and you eat, okay, and it goes into our stomach, that's how we, why is it important that we break it down? Is it going to make it all the way through our GI tract in solid form? No, it's not going to, right? So we've got to have these processes to break that down. We've got to have these processes to be able to absorb the nutrients. Okay, we have to absorb it. Okay, I tell you one of the mysteries. I feel like somebody needs to solve this mystery for me. The one thing that I can't get is corn. I can't get corn. It comes out the same way it went in. And I'm like, and I know I chew my corn good. I do not know what happens. There's got to be a myth behind this. But yes, corn, right? Okay. But that's why it's important to understand that we truly absorb what we eat. So we are what we eat, right? Okay, so think about that, okay? And then we've got to be able to get it eliminated, okay? What goes in has to go out, okay? All right, let's talk about some of the main functions of the stomach and the gastric function, okay? So we eat, food goes down our esophagus, makes it into our stomach, okay? And this is where that food is kind of mechanically agitated, all right? We got a release of a lot of secretions going on with this. Why do you think our stomach wants to secrete those gastric acids, the hydrochloric acid, the pepsin? Why do we need to secrete all those things? Because what's it going to do? It's going to break it down into what? Into liquid form, right? We got to break it down into liquid form. Because basically what that stomach is doing, the stomach's job is to break down that food you ate into liquid form so that it's in a better form that when it gets to the small intestine, we can absorb it. Okay? So we got to be able to break it down. Okay? And there's a lot of secretion. So having acid, the hydrochloric acid in the gastric and the stomach, that's very important, okay? Another thing that's very important is that we produce mucus that lines the stomach walls, okay? Why do you think that's important? What would happen if we didn't have that mucus in the stomach to line the stomach walls?
Ulcer.
The acid's going to erode it, and what's that going to cause? Ulcerations, right? What's the worst thing that happens from ulcerations? GI bleed, right? Okay, so our body naturally makes that mucus that we need so much. Okay? All right, when it gets down to the small intestine, okay, the primary job of our small intestine is to absorb. This is where we're going to absorb all of our nutrients. When that food makes it out, makes chyme in the stomach and gets dumped into the small intestine, this is where our pancreas is going to release some digestive enzymes. Our liver, all right, has already made bile, and it's going to dump through the gallbladder bile. And the whole job of bile is to help absorb fat. Okay, we're going to talk about that when we talk about biliary. Okay? Then it's going to start moving through, makes all these contractions, these mixing waves, this churning motion. And what's that called? What's that called when we're mixing and we're churning and we're moving things forward as we're growing? Peristalsis, right? So peristalsis means that that gut is doing what it's supposed to, and it's moving things forward. So when you say, hey, we need something to increase peristalsis, it just means, hey, we need something to get this stuff moving forward. Okay, we need it going in the right direction. Okay? Now remember, acid is normal in the stomach, right? Do we need acid in the stomach? Do we need acid in the small intestines? No, because it's already broken down to liquid form, right? Okay? So by the time that this chyme gets down to those small intestines, we don't need acid anymore. Okay? So there's basically an environment, it's an alkaline type environment where we don't need any of that acid. Okay? And if that acid does get down in there, what's it going to cause? Ulcerations, right? We don't need it down there. Okay? All right, our large intestine, otherwise known as your colon, its primary job is to reabsorb water and electrolytes, especially our potassium. Okay? Now, why is this important? So remember how I told you guys, okay, about getting patients to drink water, right? We need to drink water. Why does water help in the GI tract? What does it do? What do you think water does? So if our stool, is our stool going to absorb the water? Yes, but when it absorbs the water, what do you think that makes it easier to do? It makes it softer form where it's going to go through the large intestine, the colon, into what? through the rectum where they can have a bowel movement, right? Okay? That's why when you give a patient laxatives, you have to give them water. When you give a patient stool softeners, you have to give them water. They have to have that water so that it gets reabsorbed and that stool becomes soft forms. Have you ever done that? For instance, what population do you think that you would see the most at risk for not having soft stools formed?
Elderly.
Ooh, close. They don't absorb as much, but let's go the other direction. Infants. Why infants? Do they drink water?
No.
They drink a bunch of formula, right? Okay, so they're on those formula type diets. So you ever had that before where you've had a baby or you know somebody's had a baby and you see these little bitty rabbit pellets coming out? Hard as rock, right? Dry. And that's because babies don't just get water, right? Okay, like they need to. All right, same thing with the elderly, right? The elderly, they absorb, okay, so they need, a lot of times they're on fluid restrictions. They don't drink enough water to go with their stool softeners or laxatives to keep things moving. There's nobody more aware of their bowel movements than the elderly population, right? Okay, fair enough, right? All right. Now, also in the colon, this is where good bacteria is going to sit, okay? Why do we need this bacteria? All right, we need this bacteria to sit in there and kind of help. You've heard of probiotics and prebiotics? It helps with digestion and absorption, okay? And remember how we talked, and we're going to refresh that here a little later. Remember how we talked about with patients that can't eat and had to go on things like TPM? Remember how I talked about when patients are NPO and there's nothing going in the gut? Where does that bacteria go? Where does the good bacteria find itself? If we're not using it if we're not using the GI tract, does that good bacteria go somewhere else? Where does it go? We talked about this. Into the bloodstream, right? And when that bacteria, is it supposed to be in the bloodstream? No, it causes our patient to have infections and become septic, right? So when we're not using the GI tract, because patients are NPO, very high risk for infections because that bacteria will migrate itself to the bloodstream. Okay, just a little bit of a refresher here, all right? Okay, when you guys are looking, make sure you're checking that mouth, all right? You guys, most of you guys should have done your physical assessment checkoffs by now in clinical, all right? When we're looking in the mouth, I'm really looking for things like, do they have teeth? Right? Do you need to know if your patients have teeth? Yeah, because it's going to tell me whether or not they can chew and what kind of foods they can eat. So you need to know what kind of teeth that whether they got a lot of dental caries, whether they got dentures and so forth, okay? When I'm looking at the abdomen, what's one of the things that you're mainly looking for? If you're just going to inspect an abdomen, you're going to look at it. What are you looking at? I'm looking at the shape, right? Is it flat? Is it round? Is it distended like there's a basketball hanging out in there, right? Okay? So I want to be looking at that, okay? When I listen and auscultate, you guys learned this as freshmen, right? You're listening to 4 quads, each quad separate, okay? And I'm listening for little gurgling noises. If I hear a lot of little gurgling noises, okay, those are hyperactive bowel sounds. Don't really care if they're hyperactive, that means nothing to me, okay? I'm not going to know anything different if they got hyperactive bowel sounds, okay? Where I care more about is when they're hypoactive. Okay, and that means you only hear them about once every minute or so, okay, and absent. And in order for you to document that a patient has absent bowel sounds, you better have listened to that quad for 5 minutes and not heard anything. So that's going to take 20 minutes. Has anybody got 20 minutes? No, I'm not sitting there for 20 minutes, right? Okay, so when I get to the point of hypoactive, that's already enough for me to go, okay, I got to think about why we're hypoactive. Now let's think about that. Are there some times where it's normal for a patient to be hypoactive bowel sounds? Absolutely. Abdominal surgeries, right? You expect if we go in there and we do a bowel resection and we take out some dead bowel, okay, do you think it's going to take a little bit before that to get going again? So if your patient the next day didn't have bowel sounds, are you concerned? No, it's not time enough, right? Now, a week later, I might be like, wait a minute, okay? Or if my patient's NPO, right? Would I expect to kind of have some hypoactive bowel sounds if my patient's NPO? Yeah, there's nothing for that the GI tract's not working because I'm not asking it to, right? Okay? So there are some normal times. But then there's some not so normal times. What would be some not so normal times that would concern you that bowel sounds are hypoactive? What about abdominal pain? Let's say your patient's got abdominal pain, right? And you go in there and you inspect it, it's kind of distended. Okay? And you start palpating it, it's rigid and it's firm. Is that concerning? 100%, right? Because I start thinking of things like, do I got a bowel obstruction or is it curved, right? Okay, so yes, there are times where it's not so good that we have hyperactive bowel sounds, okay? Brewing, what does brewing mean? Little swooshing noise, right? Brewing's a little swooshing noise, okay? So what do you think if I listen, especially over those areas like the aortic and the renal and the femoral arteries, and I heard a brewing? What do you think might be rolling? What do you think's happening? Maybe I got an aneurysm right there, right? Because all that is a narrowing. With an aneurysm, you kind of have a narrowing, and then it'll start kind of ballooning where it's weakening at the walls. So you got to go, ooh, this might be a sign that there's an aneurysm, okay? We don't want to palpate it, because what do you think we'll start doing if you're pushing around on an area of an aneurysm? You're going to rupture it. You don't want that. That'd be a bad day, okay? Percussion. All right, what does percussion mean? What does percussion mean? Take your fingers and lay it on there, start kind of tapping it, right? Do you need to do percussion on every patient? No. What would make you want to percuss an abdomen? If it was kind of distended and round and it didn't look real normal, right? Because what am I feeling for when I percuss? If it makes that real kind of hollowed out tympanic sound, like there's air. You ever done that when you're blowing up a balloon? That's how I describe it. You blow up a balloon and you tap on it and you got that real hollowed out sound, right? What's in there? Air. But if you take that same balloon and you put water in it, is it going to have a different sound? That's exactly what it's like when you percuss an abdomen. The difference is air versus fluid. Air versus fluid. Are either one of them good? No, neither one of them are good. Okay? But that's what percussion is going to be. Now, I don't ever want you to percuss a patient that has an aortic aneurysm, because you might just be, the bad day is going to roll around where you rupture that thing. And I don't ever want you to percuss one when a patient has had an organ transplant, because you can actually make them reject the organ. Okay? Did y'all see on the news? I found this to be fascinating. I saw this on the news the other day. We now have conducted our first successful pig kidney transplant. Did y'all see that?
Yeah.
Pig kidney, not just one we made from a pig's kidney transplant. And what I found to be fascinating was, I'm thinking, why'd you choose the pig, right? Because now we've used pigs for to create valves, like to help create valves and things like that for valve transplants and stuff, valve repairs. But the pig DNA, this is fascinating. The pig DNA was the closest to human DNA of any animal. And I was like, how did y'all decide that? And that's where they took a pig's kidney and they transplanted it, and it was successful. So it's like, watch out, pig heart coming your way one day. I'm like, but I found it fascinating that the DNA was so close to human DNA. I thought that was kind of crazy, okay? So, but anyway, very interesting. Okay, so palpation, all right? So let's talk about palpation. There's a difference in light palpation versus deep palpation, okay, depending on how deep you want to push down there. Which area do we start palpating first?
Right upper quadrant.
Ooh. What do you think? Which area would you palpate first?
Lower right.
What do you think you would need to know before you palpate it? Is there any pain? Absolutely, absolutely, right? So the first thing I'm going to ask you is, are you having any abdominal pain? Because is that going to tell me where I'm going to palpate first?
Yes.
Where am I going to palpate first? Not that area. Furthest away from it, right? Furthest away from it, okay? So if they're complaining of right lower abdominal pain, I'm going to start up over in the left upper, right? I'm going to start far away from it. And which area do I do last? The pain that hurts. Why do you think that is?
The pain might radiate, so they...
Absolutely. The pain might radiate, and then is my data skewed? Yeah. Okay, because I don't really know where they're hurting, because now they're just hurting everywhere, right? Okay? All right. Now, what does rebound tenderness mean? What does that mean? That means when I push down on it, does the pain get worse or get better?
It gets better.
Pain gets better. Why would the pain get better if I push down hard on it?
Pressure cutting off.
Because I'm doing what? What does it indicate? What's the pain caused from? Inflammation, right? Okay, so if I'm guarding it, you ever done that where you hurt and you want to really push down and guard it, it makes it feel better? So that's what rebound tenderness is. I'm pushing down really hard, so I'm making that inflammation feel better, And then when I release it, the pain really hurts, right? Okay. When you think of this patient, what type of patient do you think that is? Appendicitis. Absolutely. That's kind of the go-to one, okay? Because it's inflamed, right? So any type of inflammation in the abdomen that's causing that pain, they'll have that rebound tenderness, okay? You ever seen that? And you'll even see your patients do their own because they'll come in guarding, hovered over, right? Trying to put some kind of pressure on it because they say it feels better, okay? All right, let's talk about some diagnostics, okay? All right, we're going to start with what's called a flat plate x-ray, known as a KUB. I don't even know what KUB stands for, to be honest with you. Probably some long, crazy word.
Kidney ureter bladder.
There you go. Okay, I like it. It's just been KUB for me for 20-something years, okay? All right, it's a flat plate. Well, now where this kind of become a problem is a lot of times because it's a flat plate, they do these with patients that are already in a bed, and they just slide the plate behind them and they take it, okay? So you don't always get good pictures of everything, but it's enough for them to address major issues, okay? Like they can see if there's something, a bowel has perfed. They can see if there's a mass in there. They can see if the bowel is obstructed, and they can see if there's any kind of free air fluid in there, okay? So it's very good for a very quick, like I said, x-ray can roll in with the portable, slap the plate behind them, shoot the picture, and then you've got it, okay? So it's very quick if you suspect any of those things, okay? Then we have an abdominal CT, okay? So the CT scan is going to tell us a lot more things about if there's any tumors, if there's a cyst, if there's any kind of hemorrhaging. So it's going to give us a much more detailed view of what is going on. Now there are two types of CT, well, we'll go with three, okay? You'll have a CT scan of the abdomen that is non-contrast. What does that mean?
No dye.
Means no dye of any kind, just a plain CT, right? Okay? Then your doc may order a CT scan with oral contrast, or they may order one with IV contrast, or they may order one with both. Okay? So let's talk about that. A patient, especially that's going to be getting IV contrast, what do we want to know?
Allergies.
Do they have any allergies related to what? Iodine, shellfish, or contrast dye, right? Okay. What else do we want to know? Renal function. How do I know my renal function? My BUN, my creatinine, right? Key, okay. What else do I want to know? If they're taking metformin, right? If they have diabetes and they're on metformin. Very good, very good. So that's what I want to know before I give IV contrast, okay? Now, here's the thing about oral contrast, okay? It's going to be very important. Here's the thing about oral contrast. When a doc orders CT scan of abdomen with oral contrast, anybody ever have a oral contrast? They're going to come in there with a Route 44 size drink of this orange crap that tastes like crap, okay? It's this Route 44 drink. Now, and usually they'll bring it in there and they'll set it at the patient's bedside. Now, what do you think the patient's got to do? They're going to have to drink this all, but do you think you're going to set it down there and you'll say, okay, drink this, and when you get done, let me know? It's time sensitive. So it can't take 4 hours to drink that stuff, right? Okay? So it usually falls on the nerves that you're going to have to go in there and you're going to have to be persistent, 15, 20 minutes, however, but you are going to have to get them to drink this quickly, because guess what? As soon as they're done drinking it, are they going to be able to go down to CT scan? Ooh, no, why? It's got to go through, right? It's got to circle through everything like it needs to, be absorbed and all those great things. So generally the tech will say, hey, call me and let me know when they finished it, because then we're going to set the timer for 45 minutes. Because then they're going to come up 45 minutes later when your patient has finished it. So do you think you can't just set it down there and walk off? You're going to have to get your patient to drink it as quickly as they can. Now, they're not going to like it, especially if they've ever had it, or if they're having abdominal pain of some type of kind, right? That's why we're doing it. So what are some things that you can do to help your patient drink it? So if they're in pain, you treat them for pain. Yeah. If they say, I don't want to drink it, it makes me nauseated. I feel so nauseated right now, I could just throw up, I can't drink it. What are you going to do? You think you can treat the nausea? Yeah, I can treat the nausea, right? Okay. So there's something, whatever it takes for me to do to get them to drink it, and then I go call CT and I set the timer, because in 45 minutes they're going down for the drink, okay? For their CAT scan after they drink it, okay? All right. Now let's talk about barium barium enemas and barium swallow steadies, upper and lower GIs. Anybody know what barium is? What's barium? Barium is like a chalky white milkshake. Barium is like a white chalky milkshake. Okay, so I want you thinking about that so you can think of what it looks like. White chalky milkshake, okay? When they go for a barium swallow, all right, we're going to have them drink this barium stuff that they're going to drink like a milkshake, okay? And basically it's going to help where we can go in there and we can look at that esophagus, that stomach, and that upper part in the upper GI series, okay? The enema is kind of the same thing. They're going to drink this. They're going to drink the white chalky milkshake, and then they're also going to get an enema the same way. And basically, what it's doing is it's just kind of helping us get better pictures. Here's the problem with barium. It sets up like concrete. It sets up like concrete. Okay, so I want you to keep that in your mind. Okay. So when these patients, they're going to be NPO, right? They're going to be NPO because, like I said, they're going for these procedures. And do I need them to have anything in that GI tract? No, I got to have them drink this barium. We're going to do the enemas for the barium enemas, and I need it to light up all the great things that's in there that needs to be left up for. Okay? Now, never, ever, ever, ever do you want to do this on a patient that we think has a bowel obstruction or perfed bowel. Okay? Because why? It sets up like concrete. So what do you think the biggest side effect is for barium? Constipation, right? Okay? And that constipation can lead to what? What can constipation lead to? Bowel obstruction, and bowel obstruction can lead to what? Perfed bowel, right? Okay. So what do you think after your patient has this barium enema or this barium swallow steady done? What do you think our big priority is? Hydration. Why? We need to get it flushed out. We need to get it out, right? So what are some things that you think we can do to get this barium out sooner than later? We're going to have patient doing what? We want patient drinking lots of fluids, okay? Doctor may order some laxatives to go with it if the water itself doesn't work, and we may have to roll with some enemas to also help them if that's where it's going to go to. Yes, ma'am? Because believe it or not, fiber is hard to digest. Very difficult to digest. Like they don't want you eating things like any kind of nuts or it's hard to process, so it won't get cleared out. So it'll get hung up in there. Okay, now, so let's say, when should I get concerned? Now, here's the other thing. Do you think if it goes in white, it's going to come out white? Yes. Yes, don't panic. Don't panic, okay? Yes, if it goes in white, it's going to come out white. Okay, that's okay. All right. What we also don't want is we don't want them to go more than 2 days without having a bowel movement. So it's very key that we get them drinking water quickly. We may have to go to laxatives if needed. We may have to go to enemas. A lot of times this is done outpatient. So you tell your patient, okay, if you have not had a bowel movement in 2 days, I need you to come back. I need you to call your doctor. I need you to come back in. Okay? Very important. All right, let's talk about an EGD. You guys heard of EGDs? Okay. So an EGD is where we're going to actually go in and visualize the esophagus. Okay? We can visualize the esophagus and the upper stomach. All right, so what do you think they're mainly looking for there? Things like ulcerations, okay? Then we have a colonoscopy. You guys heard of colonoscopy? Yeah, this is basically where they're going to go through the rectum with a camera, all right? And they're going to get a visualization of that colon. And they're in there looking for things like polyps, signs of colorectal cancer, okay? The proctoscopy, not as bad as the colonoscopy because they're not going as deep. They're just kind of going through the rectum and they can kind of see that lower area. And the sigmoid is going to basically be where they can see the rectum and the lower part of the colon. Okay? All of these, all right, all of these right here, some important things about all of these. Okay? Colonoscopy, you're going to have a bowel prep. Why do you think that is? Colonoscopy and the sigmoid stuff, you're going to have a bowel prep. Because if I'm taking a camera and I'm going through the rectum into the colon, do I need it to be clean?
Yeah.
I need to be clean and washed out, right? Okay, so I can see things. So what do you think, how am I going to clean and wash out that colon? What do you think is going to happen? Oh, taking it back old school with some Go Lightly. That's right. So they're going to have a bowel prep that usually starts the night before. Okay? They're going to give, whatever the doctor orders, Go Lightly comes in this gallon jug, and it's the worst tasting crap in the entire world. Oh my God, it's miserable. Okay? So they start this bowel prep the night before with some Go Lightly. If you got a really nice doc, they may give you some what they call Fleet's phosphorus soda, and it's just this little bitty 12-ounce looking thing compared to the gallons. Some docs don't like it, okay? But they're going to start some kind of bowel prep that's going to cause them to do what? Have diarrhea, have lots and lots, they'll be up all night having lots of stools because we are cleaning out that bowel, okay? Also, low fiber, same thing, no fiber. They don't need any kind of fiber because fiber does not get absorbed, so it'll actually kind of get hung up in there, okay? And so they don't want you seeing your spinach in there when they're trying to go in there and look around and stuff, right? Okay? Next thing, when they come in the next morning, they're going to come in the next morning, sometimes your doc will order them to have enemas. Okay, now this enema is really to do what? Ensure that that lower portion is really cleaned out good, right? Back in my day, we used to have to do what was called, they'd call it tap water enemas until clear. And that was miserable. That was miserable because we would have like this gallon-sized bag that we would fill up with warm water, and it would have the tubing to go in, and then it would have another little bag to go out. And you would basically give this patient the enema in, all right, and it would either come back out, or then you would try to get them to hold it as long as they could before they got onto the bedside commode. And you guess what your job is? Watching it till it's clear. Watching it till it's clear when it comes out. Making sure that it's all good and clear. Okay? So bowel prep is very important. Now, what do you think this whole bowel prep causes a risk for? Dehydration, right? So you think your patient's going to be kind of woozy, kind of tired, right? So that makes them what, a fall risk? Right? Makes them a fall risk because of that volume issue, that volume depletion. Okay? So we have to be real careful about the safety concerns. All right? And then when they come in for these procedures, all of them are given some type of moderate sedation medication. Who wants to be awake during a colonoscopy? Absolutely not. Absolutely not. Okay? So they're all given some type of moderate sedation. Now, what is the moderate sedation going to do? It's not going to take them completely under, but it's going to make them sleepy, right? It's going to kind of put them in kind of that light sleep where they can still control their airway, but yet they're kind of out of it, okay? So what do you think as the nurse, it's important for you to do when they come back to you after they've had the sedation? So you're basically making sure that they can breathe on their own, that they can hold their own airway open, right? And that their gag reflex comes back before we do what? Before we feed them or give them anything to drink, right? Okay? So if you're the nurse and your patient goes down for an EGD and a colonoscopy, they come back up to you, okay? You think you might ought to have some suction at the bedside? Yeah, because they're going to come back to be pretty groggy, right? I don't know if they're going to be able to maintain their airway or not, okay? Another thing, what does sedation make you do a lot? What do all your patients do when they've been sedated? They'll drool, and what else? When they start coming around, they'll vomit. That sedation will make them vomit, okay? So you want to have some suction at the bedside, okay? What about head of the bed? You need to keep it elevated? Yes. You need to keep it up about 45 degrees or higher. You know, I wouldn't lay them down, because you're right, they'll be drooling all over themselves. They can't control their airway because they're not completely awake yet, okay? What else? How do you know they're going to have a gag reflex? How do you know they got a gag reflex intact? So, all right, so if they alert, they start talking to me, though, we should have gag reflex intact, okay? All right, how else would you know they have gag reflex intact?
They swallow.
You can always take like a tongue depressor. If you poke anywhere, if you even remotely have them open their mouth, and you put any kind of pressure on the back part of that tongue, are they going to start gagging?
Yeah.
The gag reflex is intact, right? Okay? So we don't ever want to give them anything to eat or drink till that gag reflex returns. Okay? All right, so very important. Okay? All right, let's talk about some fecal studies. Yes, we do studies on poop.
We do.
Yes, and that, trust me, all kinds of it that you'll see. So, well, yeah, we can take stool samples, okay, and we can look for all kinds of crazy things. Parasites. Oh yes, I've had that before. Mamas had brought diapers in there with the longest worms I've ever seen in my life, and I'm like, oh my God. Yes, that we can look for microorganisms, all kinds of craziness, okay? So, fat, all right, especially when we start talking about some of these other disorders like Crohn's and diverticulitis, where you can actually see fat. It's mucus fat in there that you'll see, okay? Not uncommon, all right? Now, blood, okay, we can do an occult blood to see if a patient's got a GI bleed, all right? So we can test stool samples. Biggest things about stool samples is this. They're going to be taken in a cup, right? So we're going to put them in a cup, okay? If it's not going to go to the lab, such as your patient has got to take one at home. So if your patient goes home and you say, hey, we need to have a stool sample next time you go, we need you to collect this and put this in the cup, you got to put it in the refrigerator. It's got to be refrigerated if it's not going to get to the lab in an adequate amount of time. Okay? So you need to tell them, you know, put that thing in a Ziploc bag, triple bag it, whatever, and it's got to go in the refrigerator. Okay? Until they can get it to the lab. Okay? If they're scheduled for an occult blood, and I don't see this very often because it's usually like in the hospital, your patient will be ordered for an occult blood, stool blood, or in the ER. If they are, they can't take their anticoagulants or their NSAIDs, right? Okay. And then of course no red meats, chicken, or vitamin C, because that actually can cause a false positive. Okay. Now here's the thing. This is what an occult blood looks like right here. Okay. This is actually what's called a guaiac. This little card. Used to be back in the day. Your physician would order an occult blood, or guaiac stool, what they would call it, okay, on patients that we thought might have GI bleed. So you would go and you would take a sample, and sometimes you had to go digging for it, okay? You had to go digging for it because it doesn't take very much. It just takes a little bit to go on that card. And you would smear it on that card, right? Okay, you would smear it on that card, and then you would close the flap, and on the back, you'd take this little developer, and you would sprinkle some drops on there. And you would look for the color change, okay? And if it made the color change, I think to blue or purplish, then it was positive for blood. Then, for whatever reason, I don't know why, but Joint Commission and insurance companies said, hey, you nurses are not qualified to read that thing. You're not qualified to put the drops on there, and you're not qualified to read that thing. So what do you think they had to start doing? Nurses had to take the sample and send it down to where? To the lab to let somebody down there sprinkle some drops on it and look at the color in order to get paid for it. Yes, so then we had to wait for those results to come back. I know it sounds a little crazy, right? But that's an occult blood. So, all right, we're going to go through and do some refreshing on enteral and parenteral nutrition, because remember how I told you guys in the nutritional seminar that this would be testable material on this exam. Okay? All right, so what does enteral mean? What does enteral mean? We talked about this. What is enteral? In the gut, right? In the GI tract. What does parenteral mean? In the bloodstream. In the bloodstream through an IV, right? Okay? All right. Now remember we talked that the gut has to have something in it or it'll stop working, right? Okay? We talked about how we've got that good bacteria in there. And when our patient is NPO or our GI tract is not working, that bacteria will relocate itself to the bloodstream and they can get an infection and become septic. Okay? All right. So, enteral feedings, remember we talked about how they can go in the stomach or in the small intestine, depending on where the tube is placed and what device it is. Okay? So, what were some of the reasons that we talked about that your patient might have a tube feeding, enteral feeding? We talked about. What kind of patients did we talk about? We talked about patients that could not swallow, which are who? Who's the patients that can't swallow? Maybe there are stroke patients. Who else? Maybe are intubated patients that are on the ventilator or they're comatose, right? Okay. What other type of patients? Somebody said those that need extra calories. What kind of patients need extra calories? Your burns patients, your cancer patients, right? Remember we talked about your chemotherapy patients? They need those extra calories, and they don't want to eat as it is, right? They can't eat. They're physically able to eat, but they are not getting in enough calories to support their needs for healing, okay? And what other type of patients? What about the swallowing problems, right? Okay. Who else? Like we talked about your strokes, but what about your multiple sclerosis patients or your Parkinson's? Do you guys learn about in Parkinson's? That why can they not eat? What can they not physically do? They get to the point where the tremors are so bad they can't get the food to their mouth, okay? So these patients may very well need some enteral nutrition support, okay? What was one of the biggest risk factors that biggest complication that I talked about? Aspiration pneumonia. Remember we talked about that, right? What are some things we do for a patient that is on enteral feeding to prevent aspiration? Keep the head of the bed elevated how high? 40, yeah, at least 30. I'll go with 30, 45 degrees or higher. They don't have to be up at 90 all the time. 30, 45 is good, okay? What else do we do?
X-ray placement.
What do we do? What about if we need to lay this patient down? Can we just lay them down? Turn it off. How long we turn it off for? 30. I like the 45-minute mark, but 30 is acceptable, right? We turn it off, okay? What if we need to lay that patient down immediately? Do we have to lay the head of the bed all the way down? No, as much as you can try to keep that. Also, what do we always keep at the bedside? Always keep suction at the bedside, right? Okay, absolutely. All right. What else helps us prevent aspiration pneumonia? What do we check? What do we check? Residuals. When do we check residuals? Each shift, at the beginning of your shift, and when? Before you give medications, right? Now, why do we check before we give medications? Because if I got a bunch of residual and they're not absorbing what I'm feeding them, are they going to absorb my medications? No. Okay? Very good. All right, diarrhea, right? We talk about most enteral feedings because they're very high in glucose. They cause diarrhea. What's our concern with diarrhea? Skin breakdown, pressure injuries, right? Okay, so we got to keep them dry, okay? And we talked about overfeeding, those high residuals, all right? All right, we talked about NG tubes, okay? What were some of the reasons that we talked about why we put an NG tube down? We want to do what? We want to decompress the stomach, okay? Why would we want to decompress the stomach? So why would we want to decompress the stomach? What do we want to suck out of it? So if we got a bowel obstruction, right? I need to start kind of trying to suck and break some of that stuff loose. Okay? What else?
Overdose.
If I've got a stomach, if my GI tract, if I got dead bowel, okay, I need an NG tube, right? Because I need to decompress that as well. What about post-surgeries? If I just had a bowel resection, would you want to keep that stomach decompressed? You wouldn't want air building up in it, would you? Because if you get a bunch of air built up in there and you just had a bowel resection, what can happen? You can actually open the suture line, right? Okay, so you can cause more trauma that way. Okay? What about esophageal type of surgeries, right? Okay? So, we can also do lavage. Remember we talked about lavage. Who do we need to do lavage for? Your overdose patients, right? Or your ones that, if they've got acute hemorrhaging, like bright red blood coming out, we can lavage those out to kind of, with the cold water, try to slow that down. And we can put down the NG tubes for the nutritional support, okay? All right, when we talk about NG tube, how do we measure?
To the
Nose
xiphoid
to what?
process.
To ear, to xiphoid. Very good. We're going to make sure that we're going to lubricate it, make sure we mark our spot, right? We talked about marking our spot. Okay, swallowing kind of helps. Move it down. I know there are some of you who got to help put down NG tubes in clinical. William did, and was this the restrained patient?
Yeah, I did the restraint.
You did the what?
I did the restraint.
Yeah.
NG and Brianna.
Yeah, we did the NG
It was all hands on deck in that room.
You put the NG tube before you put the restraints on? Okay, how well cooperative was the patient?
She's very cooperative.
Yeah?
Yeah, she's just kind of confused, but she's not combative or like trying to.
Was she able to swallow for you?
Yes.
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 Okay.
She wanted some water. She's like.
She wanted the
yeah.
water. Oh, that's great right
Yeah,
there.
she called me
Definitely
the water man. That's the guy
The
that's
water
gonna give
man?
me more water.
The water man?
Yes.
So, all right, very good. Okay, so you had her swallow, all right, and then it go down pretty smooth?
The first, we feel the pressure when you first put it in.
Yes, you feel the resistance, right?
Correct. And then then we have them kind of click their chest.
Yes.
And then when it's
And you
moving
made, and you round it,
Mhm.
okay, and then it went on down, and when you got to your spot, you did what?
We did the section.
Okay, so you
Oh,
pull
wait.
back for gastric contents.
We
Did
got
you
some
get
water.
gastric contents?
We got water.
You got water that you gave her,
We got
okay?
water in there.
Okay, and then did you tape it, did you secure it?
Yes.
Very
She showed
good.
me how to properly secure it, and I just secure it.
With the tape?
Right.
Little tape that we showed you in the little video that's on there? Very good. Okay, so, absolutely. So I hope that if you guys have not got to clinical yet, I feel like the neuro floor has really been big for these NG tube things. Every time I go up there, they're putting down NG tubes, for whatever reason. But that's the stroke floor as well, right? Okay? So why'd she have to have an NG tube?
She was already on an NG tube. She was found on the. Put her on a.
But why did she have it to begin with?
She was on.
She had a systemic blood infection, and so she was confused. And
I think she had abdominal pain too.
unable to eat.
So was she getting it for nutrition? There you go. There you go. Okay. All right, so so how do we confirm placement once we put it down? Once we put it down, what's the first thing we do to kind of get placement? We're gonna aspirate what? We're aspirating gastric contents, right? We're trying to pull back and look for something green or yellow coming out of there, right? In this case, a bunch of water she drank, right? Okay? What is the most confirming way? What is our priority of confirming placement?
X-ray.
X-ray. Now, let's say we put an NG tube down. X-ray comes up and shoots the X-ray. Can you start the tube feeding? When do you start the tube feeding? After it's been read and confirmed to be in place, right? That's when we start the tube feeding, okay? Now, what about putting the NG tube to suction? Can we put the NG tube to suction?
Yes.
Yes, I can put the NG tube to suction if it has to be, even though I'm going to shoot my X-ray, right?
Right.
What am I going to watch for, though, when I put the NG tube down, and then even when I put it to suction to make sure that everything is good? What would tell you something's wrong? Coughing. So if they're still coughing once it goes down, what else? Maybe are they going to start breathing fast if they're labored breathing? If they're really anxious and something doesn't feel right to them, right? Okay. Things that might suggest to us that we put it in the lungs. But if we got gastric contents, would we be good?
Yes.
Yes, we should be good if you got your gastric contents. At any point in time, though, that your patient shows signs of respiratory distress, you need to pull it out. Pull it out. Okay? So, all right, so I can't hook it to suction without X-ray confirmation. Okay, a lot of times it's because it's an emergency. All right, but I don't ever put anything down it without X-ray confirmation, right? Because what can happen? If it's in the lungs and I start feeding them, what's going to happen? I just fill them lungs right on up with some nasty tube feeding, right? Okay. All right, we already talked about all this. I'm not going to go through that. Okay, let's talk about managing them. We already talked about we keep the head of the bed elevated at all times for patients on tube feedings, right? We check the residuals. We talked about that, right? If you pull back, okay, we put everything back unless you get more than 500 mils, right? When you get 500, I'm not putting 500 back. Would I put some of that back? Yeah, I would put some of that back. But why? Why should I put it back? Why should I put back 200 mils per liter? What am I pulling out? I'm mainly pulling out electrolytes, right? I don't want to be electrolyte depleting them, okay? As well as what nutritional support is there, okay? So I want to put it all back unless I got the 500 mils, and I'll put back part of it, okay? We talked about the changing of the tubing, right? We change that tubing about every 24 hours. Why? It's got a lot of glucose in it, so what's it going to be prone to? Bacteria and getting infections, right? We talked about always flushing with water before and after we give meds. Why? When I flush with water before, what does that do? Clears the line and lets me know it's patent, right? And then why do I want to flush afterwards? Because then I'm clearing the line of those medication particles, so I know my patient is getting the medication in the stomach where it can be absorbed, and that it's not going to sit there and clot at the end of the tubing, right? So I want to make sure that I flush it so it doesn't get occluded, right? Okay? If you got feeding cans or bottles, they can only be out of the refrigerator for more than 24 hours. And we're going to talk a little bit more about fluid overload and hyperglycemia. Okay? All right, we talked about before how these can definitely make these patients have nausea or vomiting or that bloaty, gassy feeling. We talked about diarrhea is most common. Okay, what does that make our patient a high risk for with diarrhea? Dehydration and what else? Skin breakdown and one more. Electrolyte imbalances, right? Okay, so we make sure everyone knows. Remember when we're giving the feedings, remember how I talked about most of those feeding systems will have a water bag that you can fill up with water, and we set it to flush with water every couple of hours so that we can do what? What are we doing when we do that? Why would we want to set up a feeding where it flushes with water every couple of hours? Hydration all day long, absolutely. Okay? All right? And then, oh, we're getting close to break time, okay? And then we talked about checking those residuals, right? And when do we get concerned? I'm not going to really get concerned until I get about 150 or more, and then I start going, oh, wait a minute. And why is that? If I've got a tube feeding set to go at 30, let's say a tube feeding set to go at 30 mils an hour, okay? And you got 200 back, how many hours of tube feeding is that? How many tube feedings is that? 6.5? Okay, is that a concern to me that they've got 6.5 hours of feeding just sitting there not being absorbed?
Yes.
So that tells me I've got an absorption problem, right? okay? And I'm gonna have to address that, because if I don't, what's gonna happen? They're gonna keep holding, they're gonna keep having residual, and as that residual builds up, remember my philosophy, what doesn't go forward goes backwards, and what's gonna happen? They're gonna start vomiting it up, and they're gonna do what? Aspirate it. So, all right, let's go ahead and take a 10-minute break. We'll stop important here on fluid overload. Why would your patient experience fluid overload? Because you're pumping them full of feeding and water, right? Okay? So they're always at risk for fluid overload. How do you know your patient is experiencing fluid overload? Okay, so I hear some crackles in the lungs over here. Okay? What else? I got some edema. What else? Weight gain, intake and output, meaning I got more going in than coming out. What else? What's going to really concern me the most? Fluid overload where? In the lungs, right? So how do I know my patient has fluid overload in the lungs? We already got crackles, but what else? Shortness of breath, very respiratory distress, labored breathing, deep breathing, right? What about their skin? What's it going to look like? Pale, clammy. What's their heart rate going to do? Heart rate's going to go up. Pulses will be bounding. What's their respiratory rate going to do? Go up. What's their pulse ox going to do? Go down. So very apparent signs of respiratory distress. So if you went in there on a patient that was getting tube feeding and they were in respiratory distress and you suspected their fluid overloaded, what's one of the first things you're going to do? Raise the head and bed up. Okay. What else are you going to do? Maybe listen to some lung sounds, right? I can see here where I'm at with that. What else? Maybe I'm going to put them on some oxygen. I'm going to put them on some oxygen. What else do you need to make sure that you have that's going, that's patent and good? I need to have an IV, because what am I fixing to give them? I'm going to give them some furosemide, right, to pull some of that fluid off. Okay? Absolutely. Okay? So it's very important that we monitor the intake and the output of those daily weights closely, because is that going to give me a sign that I'm getting headed that way? If I got a lot more going in than coming out, is that going to say, wait a minute, it's got to be going somewhere, right? If I got more coming in and not going out, then I'm holding on to it, right? What about weight? Remember how we talked about in heart failure, that weight gain, right? If I weighed my patient yesterday and they weighed 3 pounds heavier today, does that tell me clue in?
Yes.
Yeah, I start cluing in. Hey, I don't like this. I don't like the ideas. Because we should be monitoring for those things before they ever get to where they have crackles in their lungs, right? We should catch on to those things before they ever get to having fluid in their lungs with that, okay? Hyperglycemia. Remember we talked about how tube feeding is very rich in glucose, right? So it's going to make your patient hyperglycemic. So how do we monitor for this? What do? We're going to be checking those blood sugars. Usually if they're on a tube feeding, it's going to be every 4 to 6 hours. And they're going to be on a sliding scale fast-acting insulin, okay? Does this mean your patient is diabetic? No, it doesn't mean your patient is diabetic, and you need to tell them that, right? They're going to be like, wait a minute, am I diabetic now? No, you're not diabetic. And they're going to say, well, why do I need this regular insulin? What are you going to tell them? What are you going to tell them when they want to know why they need this regular insulin? You say that the tube feeding is very rich in glucose. It's driving your glucose up, and what am I trying to do? I'm trying to maintain it and control your blood glucose levels, right? Okay? That's what the answer to that's going to be. All right? Yes, Vaughn? Okay. It'll come back to you. Okay. All right. We already talked about aspiration. All right? All the risk involved, all the things that we would do. Okay? All the signs of it. Some of the other signs that we didn't really hit on, that sweet formula odor, trust me, you'll never forget that a day in your life when you go in there and they're vomiting up, feeding, or you're smelling it coming out of their breath, because it's a really weird, sweet odor to it, okay? Or that can even be febrile with it. Usually you're going to see the other signs way before you get to that point. You should be cluing in on it, okay? All right, we already went through, okay, aspiration pneumonia, we already talked about this. If you went in there, all right, you went in there for a patient that's having tube feeding, and you heard gurgling from across the room, okay, you heard gurgling from across the room, what are you going to do when you get over there? You suspect the aspirate. What are you going to do? You stop the feeding. What are you going to do? Elevate the head of the bed, suction the airway. Good thing you already had it at the bedside, right? Good thing you already had it there, because then you're not trying to hunt for it, okay? What else do you think your patient might need? Maybe needs to be on some oxygen, right? Okay, and then same thing, we're probably gonna wind up trying to pull off some of that fluid, okay? The only problem with aspiration pneumonia is furosemide gonna fix that problem? No. So what do you think those patients are gonna have to get?
Antibiotics.
They're gonna have to get antibiotics. They're gonna have to get aggressive respiratory treatments, right? We're gonna have to give them breathing treatments. We're gonna have to do some pulmonary toileting, try to break up some of that crud and get it out of them, okay? Risk, that 50 to 75% of patients that get aspiration pneumonia will die. That's how great it is. 50 to 75% of patients that get aspiration pneumonia will die, okay? So you gotta take care of it right away, okay? Diarrhea, okay, let's say that you notice your patient's been on tube feeding and they've done had 4 bowel movements today. There's just this watery diarrhea. Is that a diarrhea emergency? Is it emergency? No, it's not an emergency. So would it be when we just stop the feeding? No, what can we do? We can kind of slow that feeding rate, okay? We need to kind of call that doc. We need to say, hey, man, this patient's already had 5 bowel movements today. I don't think they're tolerating the feeding. Because what's the doc going to do? The doc's going to either change the feeding or he's going to have you call who? The dietitian, and see about changing to something they can tolerate, right? Okay, so because I'm going to change it, just like you do babies. You ever had that when babies are not tolerant? We change formula the same way, okay? Skin care, very important. They may need the fecal system. Remember what I talked about what the fecal system is? Kind of like a water hose. We got this water hose that actually goes up into the rectum and it goes down to this bag and it drains all that watery diarrhea. Why do you think this can be helpful? Because it's basically preventing skin breakdown because it's not letting your patient sit in that diarrhea, in that stool for hours until you can get in there and get them cleaned up. Okay, so it's really better for skin breakdown. Okay? All right, C. diff. Very high risk. These patients are very high risk for C. diff. Okay? So if you have a patient that is on tube feeding and they start having these series of diarrhea, you need to send a stool sample off for C. diff, right? Okay, C. diff has a very distinct foul odor to it. All right, so you usually kind of know when you smell it, but it's got to go down to lab to be confirmed. Okay, what kind of precautions do we have for C. diff? Contact precautions. Do we wash hands or can we foam hands? Hand wash, good old antibacterial soap and water with C. diff, right? Okay. Do we have to wait till we get confirmed C. diff to put patients on contact precautions? No. What is going to be for contact precautions? What do we think we need? Gown and gloves for sure. Gown and gloves, right? Absolutely 100%. Okay. All right. Now, if I'm going in there and I need to suction them, I could put a mask on, okay? But when you walk in a room where any patient that has contact, you have to have gown and gloves on every time, okay? All right, and then we already talked about overfeeding, okay? All right, parenteral feeding, right? That's that TPN. All right, where does TPN go? In the bloodstream. It's a way that we can give nutrition to patients in the bloodstream, right? Okay, and these are for patients that what? What kind of patients would we get TPN?
Can't use their intestines.
Patients that cannot use the GI tract for any reason. And what kind of patients would maybe those be? What about patients that are like bowel surgeries? So like bowel resection surgeries, right? Okay. So anything that has patients where they cannot use the GI tract and they are NPO. What about if they're NPO for a long period of time? Like maybe we got a bowel obstruction that we're dealing with, right? Okay. Or we've had a extensive bowel surgery, okay? Maybe what about an esophageal surgery, right? Anything where they cannot swallow and eat, and then we get TPN. What is the highest risk with TPN? What is the most infection, right? Will that kill them? Yes, they will get septic and that will kill them. So is TPN a short term or a long term? Short term. PPN needs to be very short term, okay? Very short term. It can give us all the nutrients we need, but we do not need it to be long term, okay? Because remember, I told you that GI tract bacteria will eventually go into the bloodstream, and added with the TPN risk, it's going to cause major risk for infections, okay? Now, what can TPN be given through? Can we give TPN through a regular IV? No, it has to go through what? Either a central line or a PICC line or one of the big midlines. It's got to go through a central venous type line, okay? Now, why is infection a huge risk with TPN? Where do these lines, where does the tip of a PICC line or central line sit at? Oh yes, at the entrance of the heart, right? The tip of that catheter sits up there at the superior vena cava of the heart. Well, why is that a problem? If it gets bacteria in it, where is it dropping it off at? At the heart. You think that's a major problem? Yes, kind of pretty risky to be sending some bacteria directly to the heart, right? Okay. Not only does it put bacteria on the heart, but then it's about to put bacteria where? The whole body, right? Okay. So that is why we are so meticulous with taking care of those central lines and those PICC lines and ensuring that they don't get infections because it causes high mortality rates. Okay. The other thing with TPN is that we change out those lines. We change out TPN bags and lines every 24 hours. And we change out lipids. What's lipids? Fat. We change out the lipid bags and the lines every 12 hours because they are much higher risk for getting bacteria in them. Okay? All right, patients on TPN. All right, they are a high risk for hypokalemia. Why are they a high risk for low potassium? We talked about this. Who's the three best friends?
Sugar, water.
Potassium, glucose, and insulin. They go everywhere together, right? And where do they go together? Inside the cell, right? Okay? And when I draw blood and I'm checking my electrolytes, where is those levels at? Outside the cell in the bloodstream, right? Okay? And I gotta have those inside the cell, but I also gotta have them outside. 95% of your potassium is inside the cell, and only 5% needs to be outside in the bloodstream, okay? Now, I'll get these three best friends, and why is that? Because in TPN, they will actually have glucose and insulin in those bags, okay? If you ever look at a TPN bag, it's got this big, long printout, and it's got all kinds of crap on there. It's got on there electrolytes, it's got minerals, it's got vitamins, it's got all kinds of this long list to do. You think pharmacy can just whip that up pretty fast? It's going to take a minute. So do you think you should let your bag run low? No, you need to call way ahead of time. If not, you're going to be getting dirty looks and you're going to be in trouble, okay? So, very high risk for hypokalemia because the three best friends are going to join together and they're going to go into the cells, okay? Hyperglycemia, okay? They're a risk for hypoglycemia because of the large amounts of glucose that gets added into the TPN, okay? Now, if we add a lot of glucose in there, does that mean every patient on TPN is going to be hyperglycemic? No. What do you think makes the difference in that? Do you think it varies from person to person?
Yes.
Based on how much their pancreas is secreting out insulin and they're absorbing it, right?
Right.
Okay? So, are we going to check every patient for hyperglycemia?
Yes.
Yes. These patients are going to get their blood sugars checked every 4 to 6 hours based on policy for TPN, and they're going to be on a fast-acting sliding scale. Okay? Now, why does this become a problem? If you're the one that didn't call pharmacy ahead of time and you let the bag run dry, okay, now what are you at risk for? Hypoglycemia. And why is that? You've been getting all this glucose and some insulin coming from the TPN, along with your body making what? Insulin to try to keep up with this, and all of a sudden you let the bag run dry. Your body had time to put the brakes on it? No. So now these patients have got all this influx that your body's making this extra insulin to help with this glucose, and now you just let the bag run out. Okay? So what can we do if the bag starts to run dry and you didn't call pharmacy in time? What can you do?
Glucose.
What are we going to hang? D10. D10. Here's why. Here's why. D50. I love it. She said D50. How does D50 come?
In the shot.
500 milliliters.
And 50 mils in a big syringe. So, D50 is 50% glucose, and it comes in a 50 ml syringe. How does D10 come? In a bag, and it's 10% glucose. So is that enough to kind of keep the body entertained for a little while?
Yes.
Yes, it's enough to keep it entertained for a little while where they don't get hypoglycemic. Okay? Remember how I told you they're having a D50 shortage right now at the hospital? And they're having to use D10 to supplement when they're dealing with those issues over there. Okay? Okay. And then, of course, infection risk. Okay? All that glucose and those nutrients in that TPN bag, bacteria love that. So we have to be meticulous about taking care of those sites and changing out those bags. Now, what would make you think that your patient has got an infection? What would you start seeing, and a patient's getting TPN, and what makes you start cluing in they got an infection? What do you think?
Temperature.
So they could start seeing fever. Do you think all of a sudden that they are 98.2 today, and then tomorrow they're going to just all of a sudden show up to be 102?
No.
Are you going to see a trend? Yeah, you're going to see a trend. That ought to get me thinking, what else might they have? What are you going to see? You think they're going to kind of have what? You're going to start seeing some other signs. What about things like, are they going to start looking warm and flushed?
Yeah.
What about their mental status?
Oh, we're gonna keep on.
Especially your elderly, they're going to start getting altered, right? More confused. Okay, you might start seeing some changes in mental status. What do you think happens with their respiratory rate? Starts to go up. What happens with their heart rate? Heart rate does what? Starts to go up. Heart rate's going to increase. And what do you think increases the heart rate more? The more febrile they are, the harder that heart rate's going up. It's trying to compensate and work on it, right? Okay? Yes.
Is TPN continuous?
Yes. Oh, very good. I like that question. Yes. So when a patient is on TPN, it's given by IV pump. So you got this big bag. It hooks just through the IV. It's got special tubing, but it goes right into the IV pump, and you set it just like IV fluids. So it'll go at how many, 50 mils an hour or however it's going to be. So TPN, you use the IV pump, and it goes into the central IV line. With tube feeding, enteral nutrition, it has its own feeding pump. So it still goes through by a pump, but it has its own little cartridge set, and it actually hooks. It's got a little thing at the end that looks like a little cone, and it'll either hook into the NG tube, or it'll hook right into like a J tube or a G tube, a gastric tube that it'll go into. So, very good question. All right. We already talked about getting rid of all those things. Trying to see if there's anything on there. We hit all those things on that slide already. So, okay. All right, let's go in and talk a little bit about some disease processes. All right, gastroesophageal reflux disease, otherwise known as what?
GERD.
GERD. All right, everybody knows what GERD is, or should kind of. It's the most common upper GI problem. Now, what do you think of when you think of GERD? What do people say? I got heartburn, or I got the what? Acid reflux, right? And that's because that's really what it is, okay? We have gastric contents. Where should gastric contents be? In the stomach, right? That's where all that gastric acid and stuff is supposed to stay. And why is it supposed to stay there? Because what's its job? To break down all that food into basically a chyme liquid form, right? Okay? It needs to stay there. So when we have GERD, this means that that gastric contents, that gastric acid, is going from the stomach back up the esophagus. Well, why is that a problem? Is it supposed to be in the esophagus? No. Is there any kind of mucus in that esophagus to coat that? No. So what's it going to do? It's going to start burning and eroding that lining, right? It's going to start eroding away at that lining, and then what's going to happen? It's going to create ulcerations, right? What's the worst thing that can happen from ulcerations? Bleeding, okay? That's why alcoholics, you ever heard of alcoholics that have, which this is going to be more critical care level probably for you. Alcoholics get what's called esophageal varices. What is esophageal varices? They hemorrhage. Because the alcohol is what? It's an acid, right? And it erodes away at the esophagus, and it'll cause such erosions that it'll cause varices, which will cause them to bleed. I literally had them come in before vomiting just large amounts of bright red blood, and they're hemorrhaging to death from the varices. So that's kind of where your GERD is going to come in. All right, so most common symptoms. Somebody is fired. You are fired. Nobody said anything, and I'm sure Miss Heather's over here going, "Don't say nothing, Mary. Don't say nothing." Turn. All right. Most common symptom is what? Heartburn, right? That's how we know heartburn, right? Because guess what? It's that acid making its way back up that esophagus that's causing that burning feeling, okay? They may also complain of feeling this tight sensation down in that lower sternum, okay? It feels like that tightening, okay? They may also complain of having some upper abdominal pain or even pain kind of that mid-sternal type feeling, okay? Now, here's where you don't want to get caught off guard, okay? Gotta be real careful about this, that GERD chest pain can mimic angina, okay? got what? I got chest pain. I hurt right here in my chest. Okay? And then what do you think? Do you think you should go, oh, it's probably just the GERD? Which way do you think we work this? We're going to work cardiac first, right? And then when we've ruled out cardiac, then what? Then we might go the GERD route, okay? So what we used to do in the ER is these patients would come in, okay? These patients would come in complaining of chest pain. We worked the cardiac route first, which consisted of what? EKG, our blood work, our cardiac enzymes, right? Our CKMB, our troponin, chest x-ray. And when we ruled out cardiac, then we go, oh, now let's try this. So then we used to mix what was called the green dragon. Loved it, called it the green dragon. We mixed a lidocaine biscuit, so it was like a lidocaine syrup, and with some Maalox or some Mylanta. And then back in the days, we used to go get some belladonna, some really good stuff, but now it's kind of narcotic-y, so it wasn't good anymore. But it didn't really fix them up, okay? So we mixed this green dragon, and they would drink this green dragon, and within 10 minutes, guess what? Pain's gone, and I'm healed, okay? Well, then that's kind of how we go, okay, it sounds like the GERD, because what do you think happened? The lidocaine did what?
Coated the
Lidocaine numbed that esophagus as it was going down. That Maalox and that Mylanta kind of buffered out the acid, and the belladonna just made them feel really good. Okay? I ain't lying. Anybody, y'all, somebody, there's only a few of you that are old enough in here to have babies my age, when we used to have belladonna teething tablets. Oh, yes. Oh, yeah. If my babies be teething, I get them belladonna teething tablets and start tucking them in them cheeks, and they be out, okay? I'm like, then they eventually don't even make them anymore. I was like, that's how old school we were. But that was also back then. That was also kind of a step before my parents, and I'm sure some of you, your parents may have been, what, you're teething?
All
Here,
those moms are gonna be
dip a
looking
finger
for
in a little bit
a
of
drug
whiskey,
dealer,
we'll
like,
just rub it around the
yeah,
gums,
baby
and
teeth.
it'll all okay, right? Okay, that's true, yeah. So belladonna, we don't see that around here as much, but I love some belladonna. So we would put it in that green dragon, and we would take care of that, okay? So the problem is, why do you think we worked up cardiac first and then the GERD? I'm on a time frame too, but what would happen if I go, I sound like a little girl, let me just give you a green dragon, and it went away, and it was really cardiac?
Right.
Okay, yeah, they could actually die from the heart problem, right? Okay, so we always work up heart first, and then we'll switch over to GERD with that, okay? When do you think their pain is the worst? Pain
Laying
is
down.
worse after eating, but why is it worse after eating? Because what happens when I start eating? My stomach starts doing what? Releasing the acid that it's supposed to release to help break down my food, right? Okay, so now when I got this overproduction of acid when I start eating and I'm producing too much, not only is it in my stomach, but it's making its way up the esophagus and causing that. Yes, ma'am?
Why does it only happen with certain foods though?
Because some foods are more acidic.
Some are worse than others.
I think sometimes, well, now I can't explain why chocolate over something else. Now, some things already have a natural, like tomatoes.
Yeah.
Tomato paste has an acid in it.
It's,
So it doesn't help if you eat foods that are already naturally acidic
right.
to it. I can't explain your chocolate problem. But yes, that's true. But it's the same thing with dairy, right? Okay, anybody have the dairy? When you eat dairy, you're in the bathroom in like 20 minutes. I think there's just certain stomachs that do not like things other than others, right? Okay? So, all right. Now also, why do you think pain is also worse when you lay down?
Because it's backing up.
Because it's the law of gravity, right? You lay down and all that acid in the stomach now has the perfect opportunity to just flow on down the esophagus, right?
Right.
Okay, absolutely. So what do you think we would tell these patients that they can do to help resolve this issue? They need to do what? They need to stay sitting up for about 45 minutes to an hour after they eat. Why is that? Because should the stomach be done by that time? The stomach should already be done. It already did its job. It already dumped the acid. It already broke down the food, and it should be on its way to the next location, right? So when you set up for that 45 minutes to that hour, you should not still be making acid at the end of it. Okay, that fixes one thing. What about drinking water? What is drinking water going to do? It's going to keep it what? Washed down. It's going to keep it washed down, right? So when you have them drinking water, that will help keep it washed down, right? Because acid's a liquid, right? So you're going to wash it back out of the esophagus, all the way back down into the stomach, okay? And then antacids. How is antacids helpful? Because what's it going to do? It's going to neutralize and buffer it, right? Okay? Very good. All right. Now, complications. Okay, there are complications that can be caused by this acid coming up there in the road. We already talked about that. They can have that esophageal ulcerations, right? Now, a couple things can happen with the ulceration. Either it can cause an ulceration and it bleeds, and you can hemorrhage to death, or you can keep having these smaller ulcerations that basically create scar tissue. What is the problem with scar tissue? Anybody ever had a surgery before that had scar tissue eventually around it? Because what is scar tissue going to do? Scar tissue is going to develop where it's going to wrap around something, and then what's it going to do? It's going to constrict it off, right? Okay? So I've seen before where bowel surgeries have actually developed scar tissue, and it turned around, that scar tissue turned around and basically cut off the blood supply to another part of the bowel. Because the scar tissue wrapped around it like you would taking a shoestring, you wrap it around there and tie it off, and now they get no blood supply, okay? So scar tissue is not necessarily a good thing, the more you get scar tissue forming, okay? And it can actually cause it to stricture, cut off, and then they're going to have difficulty eating and swallowing, okay? They can also get what's called Barrett's esophagus, okay? That's just more some precancerous type of lesions, okay? And then we already talked about the hemorrhaging. So, main way we diagnose GERD is how? We think the primary way, you're going to go into your doctor today, and Fawn's going to say, I think I got the acid reflux. What's the most simplest way your doctor's going to diagnose it? Huh? History and physical. Your doctor's going to say, well, tell me when this pain occurs, right? Tell me what happens, what makes it better, right? You think we can do that? Is that fair enough? When do you think they would reach the point of wanting to do an EGD? When do you think they're going to do an EGD? When there's more concern for what? Bleeding, ulcerations, right? When there's more concern for bleeding and ulcerations, okay? Remember how I tell you guys, we're going to take which route goes first? Least invasive, simple route, if that will work, before we go to the next one, okay? A lot easier for you to go in and answer some questions for your doctor than to pay a couple grand for an EGD, right? Okay? All right. Patient education. We already kind of talked about some of these. If they smoke, we should always tell somebody that smoking is bad, okay? Reflux foods, all right? Oh, there's your chocolate. There's your chocolate. See, there it is. Okay. White chocolate. I don't have my glasses. What does it say?
Contains caffeine and theobromine,
So, okay, so it contained, that's why I was like, that was really throwing me off. I'm like, what the, okay, I'm not saying that right. So anyways, so the reason apparently, according to her research, is the chocolate, I was like, well, what does chocolate have to do with it? It contains a substance that causes relaxation of the esophagus, and what would that allow the acid to do? To go up. She might not want to eat some chocolate. I don't know about you, but I like my Snickers, okay? Heartburn or no heartburn, I like my Snickers, okay? So, yeah. Also, things that more like your orange juice, because what's orange juice? Orange juice is acidic, right? Anything that's tomato-based is acidic. Anybody ever done that? Like, I love a fresh, homegrown tomato right out of the garden. Okay. You ever done that before? Put your little salt on there? And I can remember as a kid, boy, I would just be eating that tomato, and the next thing I know, my whole face was red, right? Because all that acid got on around my face and irritated my skin, right? You ever had that kid that loves the spaghetti, and they just ate the spaghetti, and then the whole face is broke out red because of the rash from the spaghetti sauce, because of the acid on it? So yeah, so they're going to kind of avoid those type of acids. No eating late in the evening. Why? Anytime we eat, we are going to stimulate what? Acid, right? So we don't want to be eating late at night, because odds are, who's going to stay awake for an hour right before you fall back asleep again? Okay? Same thing with the nocturnal snacking. I am a nighttime snacker. Like, I had to really get away from that. Who's a nighttime snacker? Who wakes up at like 2 o'clock and goes, I'm hungry? Okay? All right. I gotta go. What's your go-to food for the nighttime snacking?
Chocolate.
Oh, sorry.
Me? The biggest bowl of cereal I can find. I don't know why. There are times, I'm not a huge sleeper, as you guys can probably imagine when if you get emails at 3 o'clock in the morning, you don't think anything of it. But that's what I do. I'll wake up at 2 o'clock and I'm like, I am hungry. And I will go in there and I will get the biggest bowl of cereal. And usually my go-to cereal, and I don't know why, some Fruity Pebbles. I love some Fruity Pebbles, okay? The big bowl of some Fruity Pebbles. And I'll eat that whole bowl. And by the time I get done eating that whole bowl, I'm like, well, now I am wide awake. So I'm like, what do I need to do? Nothing better than some work, right? So I'll get my laptop out and I'll do things for about an hour or two till I get sleepy again. And then I'll finally go back to bed. But yes, I'm horrible with this nighttime. So I've gotten to where, unless my son is home, I don't even buy cereal. Because I can go through a box of Fruity Pebbles in 2 days. Like, I don't know what it is about the Fruity Pebbles, but I can eat some Fruity Pebbles when it comes to that. So yes, we definitely want to avoid late eating and drinking fluids between meals. Why do we want to drink fluids, especially water between meals? Because it keeps it washed down. We want to keep that acid washed down in the stomach where it's supposed to be. Okay? All right, let's talk about some meds. Okay, let's talk about some meds that we think can help with this. All right? Proton pump inhibitors. What's the most common proton pump inhibitor? Omeprazole, right? And what's the other one? The pantoprazole. Absolutely. Those are your two most common ones. What do you think's the main difference in the two? You can tell you the main difference in the two is the cost. The pantoprazole costs a fortune. Protonics cost a fortune compared to some omeprazole. Okay, so the pantoprazole is way more expensive. Okay, but both. Now here's the thing about the omeprazole. The omeprazole comes in a liquid as well as a pill portion, so that kind of helps, right? The pantoprazole comes in a pill. It's not really crushable, or you can give it how else?
IV.
IV, absolutely. Okay, and that's the more expensive route, especially given the pantoprazole IV. Okay, now, so these proton pump inhibitors, how do they help our patient? What are they going to do? Their job is to decrease the amount of acid that's being produced, right? So if they decrease the amount of acid, is that going to lessen the risk of this overproduction of this acid and going up the esophagus? 100%. 100%. Okay? Now, what do you think, the reason I say that is, every patient at the hospital has to have two things. What are they? DVT prophylaxis and what else? DVT prophylaxis and what else? They have to have an anti-ulcer of some type of why? What are we trying to prevent? GI bleed. And why are we trying to prevent GI bleed in the hospital? So it took a lot of years, probably, and a lot of people dying, okay, that we realized we were seeing a lot of GI bleeds in the hospital. Patient would come in with a femur fracture and die of GI bleed. Should that happen? We were like, how did that happen, right? Okay, so we were seeing a lot of GI bleeds happening that had no reason. And finally what we discovered was, what do you think was happening? The physiological stress. You ever done that when you're really stressed out? You seem to feel like you got that heartburn more. Okay? You're producing more of that gastric acid. So the physiological stress on your body from whatever the illness or injury was increasing the acid production. Now, what do you think this acid was doing? This acid was eroding away at the stomach and the GI lining, which was causing what? Ulcerations, right? It was causing gastric ulcers. And the end result is what? GI bleed, hemorrhaging, okay? So finally we got smart and we said, hey, you know what? We can fix this problem, okay? We can give every patient in here and make sure that they are on something that will help lower this risk of this increased gastric acid production to do what? To prevent the GI bleed. So every patient in that hospital should be on a DVT prevention and a gastric ulcer prevention, okay? And this just happens to be where usually it's going to be the omeprazole or the pantoprazole because we found them to be more effective.
Why the hypoglycemia do that? What is it?
You know what? That sounds like a great thing that I want you to look up at break and you tell me. I want you to research that for me at break and I want you to tell me. You'll be smarter in the end by doing it, okay? All right. H2 receptor blockers, okay? What are your H2 receptor blockers? What's your most common one? The famotidine, right? Okay, you see this one, guys, more common, okay? And how is this helpful? Because H2, all right, the H2 receptor is going to actually decrease the hydrochloric acid, okay? So we block the H2 receptor, it will decrease the acid. Here's a trivia question for you. What other time would you give a patient a H2 receptor blocker?
Allergic reaction.
Oh, I like it. Who said that? Allergic reaction. The one that's got anaphylaxis. Okay. And why would we give a patient having anaphylaxis an H2 receptor blocker?
Because it helps,
It's blocking what?
it blocks
The histamine response. Because let's think about this. What actually kills the patient in an anaphylactic shock? The histamine response, because when the histamine response hits you, what's it doing? Causing bronchial constriction, causing fluid overload, right? All this massive type things that happen. So when you give a patient having an anaphylaxis reaction, famotidine, you are helping block the histamine response that has been triggered by the reaction itself. So yes, I used to give this to patients all the time in the ER, because you can give famotidine you can give it in a pill, you can give it in a liquid, or you can give it by IV. Okay, so I used to give it IV a lot. So, all right, kind of some same side effects that go along there. We want to take this with meals and at bedtime, right? With meals and at bedtime. The proton pump inhibitors, how many times do you take those? Once a day. When is the best time to take the proton pump inhibitors? First thing in the morning, at least 30 minutes before you eat. Okay? You guys giving those meds in clinicals?
Yes.
Yes, okay. I don't usually get super worked up if that thing is due at like 7:30 and the meal ain't coming till 9, okay? Because I kind of got my hour leeway in there. As long as they get it 30 minutes before they eat is when it's most effective, okay? Now, remember, we want to stay awake. Yes?
Okay, so if they were in an IV clip, why would they get it like more like not after they eat?
Usually what I see is, here's how pharmacy does it. A lot of times the IV push are for patients that don't eat. Does that make sense? Like your patients that are getting tube feedings, that are on the ventilators, okay? And so those are patients that are usually getting a continuous feed. Pharmacy will automatically time it for 9 o'clock. So if they're getting it IV, they really should not be getting it IV if they can eat. Usually it's for your tube feeding patients. But pharmacy doesn't always know that. Pharmacy doesn't know if your patient can eat or not. So a lot of times it falls on the nurse to call that pharmacy and say, hey, can we switch this from IV to PO, number one, because it's what? Cheaper. And then 2, have them retime it for normal breakfast time. Because what will happen is, what you're going to see is you're going to have patients that are in the critical care units that are on tube feedings and on the ventilators, right? So they're getting the pantoprazole every morning at 9 o'clock because they're on a continuous feed. What's going to happen is when that patient gets moved from the ICU to a floor bed, does pharmacy know that they're not needing it anymore? So a lot of times nurses will never call a pharmacy and say, hey, can we switch this to PO, and hey, can we retime it? We just keep giving it IV because it's easier, but it's so much more expensive. And then it's not even falling in suit with what time they eat. Because if they're getting a continuous feeding, getting it at 9 o'clock every day, it's still set at that 24-hour mark, even though they're getting feeding all the time. If they're not getting a continuous feed and they're actually eating, it needs to be 30 minutes before they're done. A lot of times pharmacy just doesn't know and nobody's called. All right, what do we know about antacids? When can we give antacids versus other medications? An hour before or an hour after, right? We never, ever, 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 ever give a patient antacids at the same time that we give other meds. Why? What's going to happen? They're not going to absorb. The antacids will affect the absorption, okay? So you always give antacids an hour before or an after other medications, because that's giving those other medications time to absorb. Okay, now how is antacids beneficial? What does antacids do? It's going to do what? It's going to neutralize, it's going to buffer out that acid, right? Okay. So when do we want to take that? We want to take that anywhere up to 1 to 3 hours after mealtime. They can take that an hour to 3 hours after mealtime. And that's because what happens? I've ate, so I wait, and I take it an hour later because it's going to finish buffering out that extra acid that still may be floating around. Because do I still have to have acid? I still have to have acid in my stomach. I don't want to completely shut that thing down, right? But what I want to do is I want to give it an hour to let it do what? Work in my stomach, break down that food, do all that churning it needs to do, and then I want to shut it down, right? Okay? So that's why I want to wait an hour to 3 hours afterwards. And then at bedtime. Why is bedtime a good time to take antacids? Because you're fixing to do what? You're fixing to lay down, right? And now you're going to increase that risk for that stomach to come from that stomach up that esophagus, all right, and kind of create you some problems. So you want to kind of buffer it out then. We got several different types of antacids, right? We got calcium carbonate, which is our Tums. We got magnesium oxide, which is that Magox. And we've got the aluminum and the magnesium, which is your Malox and your Mylanta. Okay, all of these can be over the counter, okay? We don't talk much about Reglan anymore, so we're not going to kind of go into that. Kind of breaks my heart because I was a huge fan of it. But I think they found like they feel like there's some kind of side effects that really kind of outweigh the risk. We used to give this metoclopramide, this Reglan a lot, to help increase gastric motility. So if you had patients that were like post-surgery or post-bowel surgery, we would actually give them this metoclopramide to kind of help increase peristalsis. Or if you had a patient that had things like a bowel obstruction and you're trying to get the bowel obstruction loose and get things moving again, we would give this to increase that motility. But they don't really do it as much anymore. Okay? Anti-ulcers. I love some sucralfate. Okay? Sucralfate is the generic name, otherwise known as Carafate. What this is remember how we talked about how the stomach naturally produces mucus to kind of make a layering and protect it? Sucralfate is that takes over for that. Sucralfate as a it's like putting a lubricant, okay, a protective layer lubricant over that stomach to help be a barrier. So a lot of times you will see patients, especially in the ICUs, all be on a sucralfate. Because not only are we hitting them with like a proton pump inhibitor to kind of help decrease the acid, we give them the sucralfate to kind of help add some of that extra lubricant coating so that they don't get these ulcerations. So, very good medication. Okay, you guys ready for another break? Real quick though, before what do you think of? Something that's not where it's supposed, it's just an outpouching area, right? It's an outpouching area that's not where it's supposed to be, okay? So when we talk about hiatal hernias, okay, it's really what's going to affect the stomach and the diaphragm. Okay, so you see the diaphragm right here, across that separates. What is the job of the diaphragm? What is the diaphragm? It's what? It's a muscle. And what is its primary job? The diaphragm's primary job is to separate the chest cavity from the abdominal cavity. Now, why is that important? If that muscle wasn't there to serve like this big old wall, what would happen? What would happen with the abdominal cavity? All of those contents, like your intestines and stuff, would do what? Find its way up into the chest cavity. We ain't got no room up there for that, right? Okay? So that's all it's talking. Because I've had trauma patients before that have had a ruptured diaphragm, and you know how I diagnosed them having a ruptured diaphragm? Vowel sounds where? Way up in the chest. And you go, well, that will sound right. Right? Okay? So that's all the diaphragm is it's a muscle that separates the chest cavity organs from the abdominal cavity organs. Everybody stays where they're supposed to be. Now, the other reason the diaphragm plays an important role is what does the diaphragm do when you take a deep breath in? Where does it go? It goes down because what does it do? It pushes the abdominal organs down to allow you to do what? To allow you to take a big deep breath in and get in all that volume in the lungs that you need, right? That's its primary job, that it helps with that as well. Okay, so when we have this hiatal hernia, what actually happens is somehow part of the stomach has worked its way through, all right, has worked its way through the diaphragm up there towards the esophagus. Well, that's not going to help, right? That's not going to help, because now what do I basically have? Two stomachs, right? Okay, because when I eat and it goes down the esophagus, is it going to get down there and it's going to stop right there? Yeah. So now all of a sudden it thinks I've got this really small stomach that it's got to try to do what? Make its way through to get down here to the bigger part of the stomach, right? Okay? And how it breaks through the diaphragm, there's actually some weakening of the muscles. And what do you think are some things that we do that causes some weakening? What's the number one thing that we do? Huh? Like heavy lifting? You guys ever done that where you're just really bearing down and you're heavy lifting something and you're like, oh, that did not feel real good, right? Okay? So we've caused some type of weakening in that diaphragm that lets that stomach part get up there, okay? Now, what do you think is the biggest problem with this? When I eat, am I going to eat and is everything I eat going to fill in that little bitty spot and then go down the stomach? No, so I'm not going to be able to eat as much as I normally would. You think I'm going to feel full sooner? I'm going to feel full sooner. You think there's going to probably be some pain with that? Absolutely, okay? And then what's going to happen is, there's other things. This can actually get strangulated. What do you think is going to happen if that gets strangulated? What's going to happen to the blood supply? Blood supply is going to get cut off, and now what? I'm going to kill off this part of the stomach, right? Okay? And it can also, aspiration of stomach contents. Why would you be at risk for aspiration? Because it can't go down. It's going to do what? Come back up, right? Okay? So there's definitely some key things with this, okay? All right, so one of the most common symptoms is they're going to complain of heartburn, and it's going to be worse after eating, right? Okay, because why would they complain of heartburn? Because that's still a stomach portion, so what does that have in it? Acid, right? And is that acid already a step closer to the esophagus? Yes, okay, so they're going to complain of this feeling of this heartburn, okay? They may be feeling full, they're going to feel full a lot sooner, all right? And this regurgitation, right? Because like I said, if you just sat down and ate a steak dinner and you've got a little bitty portion of the stomach that it's got to go to first before it can get to the other, all right, it's going to start coming back up because there's no room for it, okay? So they'll have that regurgitation or they'll start vomiting, okay? We can generally find this on an abdominal x-ray. We can also do a barium swallow, all right, to kind of show that. And a lot of times they'll just skip all that and they'll do an EGD. Because when they go in with the EGD and they go down, they can actually see it. Okay? Now,
Perfect, man.
yes.
What were we looking at? Is that somebody's large intestine going back up? Or?
That's what that looks like right there. That looks something crazy.
Yeah.
That's your colon right there, but I don't know why it's going back up there. That does not look right, does it? I just thought it was a cool picture.
I thought you had something in mind while you showed it.
Oh, look, they don't pay me enough to read x-rays. So, no. Okay, so we can diagnose this. Now, does every hernia have to be surgical? No, so we're going to try to medically manage it first before we go the surgical route, right? Okay, so some things that your patient can do to medically manage it is same thing as the GERD. We don't want them to lay down, right, until after an hour from eating, right? We need to try to let that stomach kind of make its way through the little stomach to the big stomach part and let it get all broken down and absorbed, okay? Small meals, okay? Because eating smaller portions, your stomach's going to be able to tolerate, that herniated stomach's going to be able to tolerate that better than large big meals, okay? We don't want to be on any type of anticholinergic med because that will delay emptying in the stomach, okay? They're going to be on some type of proton pump inhibitor or an H2 blocker, okay? Now, if your patient starts having these, it's going to suggest that that thing's become strangulated, and that is a medical emergency, okay? If they have abdominal distension, and I'm talking distended, rigid, board-like, hard abdomen, okay? They're going to have severe pain with this. And then, of course, they're going to have fever, and there will be tachycardia, okay? Because of the fever along with the sepsis they got going on, okay? They are going to have to go to surgery because that suggests that this thing has become strangulated, meaning that I don't have any blood supply going to that area, and I need to save the stomach part, okay? So they're going to go in, if they have to surgically treat it, they're going to go in and they're going to actually do what's called a Nissen. Okay, this is kind of cool looking, right? They're going to do a Nissen, okay? And what they're going to do is they're going to actually take that herniated stomach and they're going to reduce it back to where it's supposed to be, okay? Or they can go in and they can take that herniated sac out and then close it off. And we got to suture it off, okay? And the reason that it's important that you know why and what they're going to do right here where they're going to surgically close that area, okay? Because what is that? That's esophagus meets stomach, right? You see how they've taken it down and they surgically wrapped it around there and they closed it off? It's important because some of the things that we're going to do for these patients post-care, you need to be thinking about they got what? They got sutures around the stomach area. Sutures around the stomach area. Because what's the worst thing that can happen to those sutures? they perf open, and next thing you know, you got a big fat mess, right? Okay? So we want to make sure we keep the head of the bed elevated, because when I keep the head of the bed elevated 30, 45 degrees, what is that going to do? Is that going to increase pressure or decrease pressure in the stomach? It's going to decrease pressure because of gravity, right? Law of gravity. Do I want increased pressure in the stomach? No. I want to let these sutures heal. I want everything to heal, okay? When your patient is coughing, deep breathing, or getting up, because y'all know how I like them to ambulate, okay? Y'all know I like them to get them up and walking. They're not going to want to, but we also have to, because of the pain, but we want to protect the suture. The sutures you can't necessarily see internally. We have to protect that suture line. So what do you think something we can do? What can we do to protect that? We're going to support. What can we support with? A pillow. A pillow, right? Okay? So anytime you have them coughing and deep breathing, or you have them ambulating, or they're getting out of bed, have them take that pillow and brace themselves with it and support it so that they don't rupture that suture line, right? Okay? Soft diet. Soft diet for the first week after surgery. Why? Why would we want soft diet? It's easier on the stomach, right? It's not going to strain the stomach. Easier on the stomach, okay? We don't want this patient burping, belching, vomiting, or none of those things. Because what's going to happen? What happens when I do all those things?
Pressure.
Increases pressure, and what can happen when I increase pressure? It can rupture that suture line, okay? No carbonated beverages, right? No carbonated beverages for that very reason, right? We don't want to do anything that's going to increase the pressure. Early ambulation, no heavy lifting. Yes?
So if you don't treat a hernia by surgical treatment and you do medical treatment, does it make that stomach shrink back?
No, what they're doing is they're trying to take a non-invasive approach. It's not going to go back where it needs to be. You're just avoiding surgery at that time. You're trying to delay it. You're trying to prolong it. It's not to say that they probably eventually will need surgery. You're just trying to delay it. And you're trying to manage it without it going crazy. It won't go back to where it's supposed to. Good question. Okay. How many of you guys in clinical, y'all know how I am about getting these people up. How many of you got your patients up out of bed and walking? Yeah? Yeah? I didn't see a whole lot of hands. Who's got their patient out of bed and walking? I like it. Okay. All right. What kind of patients were you up and ambulating? How many of them were surgery? Okay. Fantastic. And what are some of the things that you notice about getting post-surgery patients up out of bed and walking? They don't want to go. Because why? They hurt. So do you think you probably ought to treat their pain before you plan to walk them? That will be helpful. Okay. What else have you noticed? They're slow. Why are they slow? They're weak or they haven't walked in a while, right? So is that a huge safety thing? Yes. So a lot of times, did anybody else get a helper? So the helping hand to go along with them? 6A. Anybody get some patients on 6A out of bed with chest tubes and IV pumps and all that craziness? What's the other reason why you think nurses don't get up and walk patients? It's a hassle, right? You got to tote all that crap, and you got to have some extra hands and so forth. Very important that you ambulate these patients. But it does take some planning when to do that. So, very proud of you guys for ambulating. Yes. All right. Let's talk about esophageal cancer. Okay. Elderly people are your greatest at risk. All right. Especially along with those that smoke, and your alcoholics will kind of fall in there. Okay. Most of these tumors are kind of in the middle or the lower area of the esophagus. This is actually what it's going to kind of look like. This is the esophagus coming down to the stomach area right here. They're going to have these little ulceration areas, right? These tumors right in there, okay? And it will kind of appear as an ulcerated lesion, all right? And the bad thing is these are pretty close to what? Your liver, your lungs, your lymph nodes. Okay, that's how they're going to metastasize, okay? All right. A lot of times with esophageal cancer, though, it's already well advanced way before you ever see any kind of signs. That's the crappy part about it, okay? Now, what do you think we can do for those patients that are kind of high risk for this? What kind of routine, because we do a lot of yearly routine things for preventative. What do you think this type of patient would need? A yearly
Endoscopy.
EGD, right? Okay, a lot of these patients that are very high risk, they would need a yearly EGD where we can go down there and look in the esophagus, okay? because a lot of them, by the time it's found, it's way too late in the game, okay? One of the most common things is that they've got that progressive dysphagia, okay? And then they feel like every time they eat, the food won't go down. Well, of course it won't go down, because why? I got this tumor blocking my esophagus, right? Okay, it's got a narrowing part of the esophagus because this tumor is kind of blocking the way, and food can't go down, okay? By the time they start having a lot of substernal pain or back pain, it's already kind of way late, because why? Why is it already way late? Because the tumor is already there, and it's already developed, and it's already closing off the esophagus, right? Okay? Then you'll kind of they'll have that typical weight loss, and then they will complain of choking, because guess what? What's it going to do? It's not going down, so they feel like they're choking on it, and they'll start getting that hoarseness in their voice. Okay? Do you have a question?
No,
Okay.
I got it.
Okay, so EGD, very most common way, and they'll go ahead and biopsy. They can go ahead and biopsy the tumor down there. The more important part of this that you guys need to know about is these surgeries. Okay, now I don't want you to have to know all the funny names for these surgeries. You need to be able to recognize and go, hey, that looks like that could be a surgery. Okay, it's more about the care. Okay, so we can go in and we can remove part of the esophagus. We could remove all of the esophagus. Imagine what that's going to look like, right? We take out their whole esophagus, okay? We can take out part of the esophagus and reattach it to the stomach, okay? And we can also take out part of it and use part of the colon as the esophagus, okay? That's what the picture was about, William. But, I mean, like, so we can do all kinds of things. But you got to think about what how invasive that surgery would be if they went in and removed part or all of your esophagus, and then pull the stomach, then somehow trying to find a way to reattach it to the stomach, or take part of the colon and make you an esophagus, right? Is that going to be a pretty extensive surgery? Oh, 100%, right? Okay. So guess what these patients aren't going to be doing? They're not going to be eating for a long while, right? They're not going to be eating for a long while. Okay, so do you think they're going to have some nutrition? So what kind of nutrition are they going to get? Huh? Parental. They're going to get TPN. Yes, ma'am.
I was gonna say, I just had a patient with this cancer, and he was severely malnourished and like bones, and we had to put a feeding tube in him, so he couldn't swallow, like he couldn't do anything, he could barely urinate.
So he had a peg tube, or he had a
Yeah,
peg tube? Yeah. So went for. So why would you think? Because now eventually she's talking about this, right? If you got esophageal cancer, and they've had to do this major surgery. I mean, I'm talking several months. They're going to put in like a peg tube or G tube, because where's the nutrition going? It's either going to go into the stomach or into the upper small intestine. So am I bypassing the whole problem? Yes, I'm bypassing the problem. Okay, but generally they start this out where you're going to be on TPN. All right, we're going to be on TPN for nutrition. They're going to be on IV fluids for hydration because they can't drink. They won't be able to drink or eat anything. Okay. We're going to put a lot of times they're going to come out of surgery with an NG tube down. They may come out with an NG tube down, because why? What am I going to try to do? The surgeon, a lot of times, if they put an NG tube down, they're going to put it down in surgery. And they're going to come back and it's going to be hooked to what? Suction. And why is it going to be hooked to suction? Because what do you think I did? I didn't went in there and I went to butchering on this esophagus. What do you think I'm doing? What's going to be happening? I'm bleeding, right? I may be bleeding. And is the bleeding normal? Some bleeding's normal. But where's the blood going to go to? To the stomach. And what is the stomach not like? And what happens when you get blood in the stomach? They start vomiting, and then now what's my problem? Now I'm about to screw up this whole thing, right? Okay, when they start vomiting. We don't want them to vomit, okay? So if you ever have a patient that comes back from any type of GI surgery with an NG tube in place, you do not touch it. If the patient pulls it out, pulls on it, what do?
Call
Restrain. Okay? If the patient pulls on it, do you go ahead and pull it out?
No.
No? Do you push it back down?
No.
You leave it in place and you get on the phone with that doc, because what do you think they're going to have you do? They're going to probably have you x-ray it, and then if there's a problem, the patient's going to have to probably go down to interventional radiology or back to the OR, because do you think there's going to be some complications with trying to put it back down? 100%. You ain't going to be in there shoving at the bedside, okay? So we don't push it back down. We don't pull it back out. We leave it in place and we get a hold of that doc when it comes to that, okay? Now, Long periods of times, yes, they will probably have to have, because like I said, it can be several months. Can I leave TPN going for several months? No. And why would I not want to leave TPN going for several months? Because what's going to happen? I need my GI tract back to working, right? So if I put in a PEG tube or a G tube in the stomach or that upper small intestine, am I going to get the GI tract back to working?
Yeah.
Yes, I'm going to get the GI tract back to working when I'm using it, right? Remember, the esophagus is off limits. The stomach and the rest of the small intestine is good to go, right? Because my esophagus is my problem. So a lot of times they're going to put in a place, a PEG tube or a G tube, where I can then feed these patients enteral feeding for a long period of time without letting that gut go several months. What do you think would happen if I gave TPN for 3 months and didn't use that GI tract? I'm probably going to kill off the bowel. I'm probably going to kill off the bowel because it's not being used. So we don't want that to happen, okay? So long-term feeding will probably come from some type of G tube or PEG tube with enteral feeding, okay? Now, depending on the extent of the surgery will really depend on how long this takes. Some of these surgeries aren't super crazy. If they just went in there and they removed a few inches of the esophagus and took out the tumor, is this patient going to get better than one that you had to remove the whole thing? A lot quicker, right? Okay? So, when that time comes that these patients can go back to eating, we've got to have a swallow study first, right? We don't ever give any patient something to drink or eat that has any type of swallowing difficulties or challenges without doing a swallow study first. Anybody get to see a swallow study? I feel like some have got to see the swallow study, right? Okay. Who does swallow study? Speech therapy. And what did you notice the most about the swallow study? What intrigued you the most that they did?
It went down so fast.
Yeah.
It went down so fast.
Yes.
What do you mean?
The food that they gave him, like, and then it was dying in the thing, so like we was watching them swallow, and it was like so quick.
And you could see where it went. Yeah.
So we didn't aspirate it.
Yeah. And then how did they assess for if they aspirated or not?
It was like
Choking, coughing, spitting up things. Yeah. Did you guys do a swallow study where they tried different thickness of liquids? Yeah. So you guys saw how they did the different thickness of the liquids, and they saw which one worked better or not. Yes. Swallow studies are pretty very interesting on how they do that. Okay. But we always want to make sure that they have the swallow study before, and then we go from there on how thick the liquids or what type of diet they're going to go on. Okay. Now, when they can go back to eating, and this is on any surgery patient, more specific to GI, when a patient comes out of surgery, okay, of any kind of surgery, all right, do we don't just go ahead and get them a regular meal tray? No, we're going to start out with what first? Clear liquids. Why clear liquids first? A little bit easier on the stomach, a little bit easier to digest, and if they start vomiting, they're only vomiting up a little bit of liquid, they're not throwing up big meals, right? Okay? All right, what do we never, ever give them?
red, yellow.
Anything with red dye in it. Nothing with red dye in it, right? Okay? And if they tolerate the clear liquids, then we move them to what? We can move them to a full or soft, full liquid or soft, right? Which are things like what? Your puddings or some
Ice
oatmeal,
cream.
right? Some milkshakes, things along those lines, right? Okay? And before we advance them to acrylic. Any patient that has had a GI surgery, when they get to start eating, we need to go with soft, small, bland when they progress. We're going to go bland, right? Small, bland. Okay, we don't want to add anything with spices in there. We don't want to do anything that's going to stimulate acid production or start irritating any kind of ulceration. Okay? And then, of course, we keep those patients in that upright, in that head of bed elevated 30 to 45 degrees. Okay? All right. When these patients come back with NG tubes, are you going to have some bloody drainage at first? Yeah, you just cut on the esophagus, right? You just went to butchering on them. Yeah, you're going to have a little bit of some blood. Okay? So you're going to do what? You're going to monitor that drainage. You would expect bloody drainage for about the first 8 to 12 hours. Okay? If you had a patient and they came back and 4 hours later they only had about 50 mils of blood in the container, are you okay with that? 50 mils. 50 mils in the container over about 4 hours. So we're talking a little over 10 mils an hour. Is that okay? Are they hemorrhaging? If you hooked that thing up to suction and 2 hours later you saw 200 mils in that container, would that question you?
Yes.
Would you think they're hemorrhaging?
Yes.
Okay, so you're going possibly. But how do you know that they're hemorrhaging? What would you do as the nurse? We got to start doing some assessment stuff, right? So what would you assess for this patient that might be hemorrhaging?
Blood pressure.
So you're gonna go with what? We're gonna get some vital signs, so you're gonna look at what? Heart rate. Would you expect heart rate to go up or down? Heart rate's gonna go up. What your blood pressure? What do you expect your blood pressure to do?
Down.
Blood pressure to go down. When your blood pressure is already hypotensive, is that good or bad?
Bad.
That's a late sign. It means you were way behind the ball game. Okay? What are some early signs that your patient is hemorrhaging? If you went in there 2 hours later and you had 200 mils in that container, what are you going to see? Because if you see that patient from across the room and you open the door, what are they going to look like? They're going to look like crap, right? You're going to open the door and you're going to be like, they look like crap, okay? They're going to look pale. They're going to look clean. What do you think their respiratory rate's going to do? They're going to be breathing faster, right? Their heart rate's going to be what? Heart rate's going to be tachycardic. What are their pulses going to feel like? Come on. High volume.
Threading.
High volume's bounding. Low volume's what? Weak and thready, right? Okay, so when I check them pulses, they're going to feel weak and thready. The blood pressure should not even, what if you, okay, let's do this. But let's say you check their blood, let's say you check them. Heart rate is 150. Oh, my blood pressure is 110/70. So I'm going into shock, but would you go, well, blood pressure ain't low yet, I'll just wait on it.
No.
No, right? Because when the blood pressure gets low, we are already way behind, right? Okay? So now we're going to, so what do you think some things that you're going to do? What are some things that you could do? Now, normally I would tell you to lay this patient flat. Would I tell you to lay this patient flat here?
No.
No, we're going to keep that head of that bed about 30 degrees, and then what can I do? I kind of elevate those legs a little bit. What else do you think? We're going to get some IV fluids, right? We're going to get some IV fluids. They're going to probably, because they're already pale and kind of clammy, and we're kind of thinking we're hemorrhaging, they probably going to need to go on some oxygen, right? What if the doc says, okay, remember, they're only 2 hours post-surgery. The doc says, okay, well, go ahead and draw a CBC and tighten across them for 2 units, okay? You draw the CBC, and you tighten across them for 2 units. But the CBC comes back with a normal hemoglobin hematocrit. What do you think? What do you think? Hemoglobin comes back, but you call the doctor and you say, hey, hemoglobin hematocrit's normal, but heart rate's still 150. Now their blood pressure is 80/40. Why are you going to still give it?
Your volume's related somewhere.
Because you're catching them before you're dead. I like where you're going. I'm not going to let them down me. But what I'm getting at is, when I draw blood on a hemoglobin hematocrit, is it going to show me that they are hemorrhaging right now? No, that's several hours down the road. It takes 4 to 6 hours for a hemoglobin hematocrit to adjust to them hemorrhaging. That's why when I used to fly trauma patients all the time, and I would go in there and I would pick up a trauma patient somewhere at a hospital, and they would say, well, their hemoglobin hematocrit's that. I'm like, I don't really give a crap. I don't care what their hemoglobin hematocrit is. And they look at me like I'm an idiot. I'm like, I need 2 units of blood and I'm leaving. Okay? And they just be like, why? And I'm like, just because I said so and I'm leaving. Okay? But the reason being is, I did kind of roll like that a lot. I had to. That's exactly right. Stop arguing with me. Okay? I mean, actually, it was kind of funny. I mean, you'd be surprised too. Sometimes, I had a doctor one time, I was living with a patient. This lady really, really needed to be intubated. And he refused to intubate her in the ER. And I was like, okay, well, I'm going to fix this problem. He's like, well, you're not intubating this patient. And I am, and I'm about 5 minutes when I get to this helicopter. Because the minute I get out there, she's no longer yours, she's mine. Okay? And that's how I would roll with that. But the main thing is you got to treat it early. I'm not waiting on the hemoglobin and the hematocrit. So what I'm saying is, when you have any patient, I don't care if it's a post-surgery, I don't care if it's a GI bleed, I don't care what it is. Do not wait on a hemoglobin and hematocrit to show you that they're hemorrhaging when all the physiological signs show you they are hemorrhaging. Okay? Yes?
But don't on the orders, does it say, that, like, I know my uncle's in the hospital, it says, like, the order says, give the blood if hemoglobin gets to this level.
Okay, that's on a, yes, that is on a standard protocol order. Okay? So for instance, if you've got a patient, these patients will usually go to ICU. So let's say this patient's in SICU, and I call that doc, and I said, hey, I got 300 mils that just come out of this thing in 2 hours. Their heart rate is now 160. This is their blood pressure. This is this. I think they're bleeding. That doctor's not going to make you wait until that. You see what I'm saying? It's different. But what you're dealing with is, here's what it also works. So let's say you got a GI bleed. Let's say you got a GI bleed that's admitted, and they got a couple of units when they came in, because let's say their hemoglobin was 6 when they came in. Okay, hemoglobin was 6, and hematocrit's like 18, okay? Hemoglobin came in and there were 6. I gave them 2 units, okay? Then I recheck the hemoglobin 12 hours later, and now let's say it's 9. Better? Yeah, much better, okay? So what do you think they're gonna have you do? They're gonna have you recheck that hemoglobin the next day? Yeah, the next morning they're gonna have you recheck the hemoglobin. And that's where the standing order is gonna be, is hey, hemoglobin's now 9, but the standing order will say transfuse 2 more units or transfuse another unit if the hemoglobin's less than 8. That means that the next day, when you draw that hemoglobin on a patient that's got a known GI bleed, okay, when you draw the hemoglobin the next day, you're not waiting on the doc to come deal with it. You got a standing order that says I can transfuse another unit if it's less than 8. Same thing with sickle cell patients. If you got a patient that comes in with sickle cell crisis, they're going to give you a standing order that when you look at that hemoglobin, if it's below this, go ahead and do this. Does that make sense? So don't ever be afraid in a patient though that's got an acute issue going on that you call them up and you say, hey, because you're going to transfuse without it ever getting to that point. Okay? Yes?
So what would be the, number that you said that you, okay, this is kind of GR.
Okay, it's going to, so in a suction canister, when you've got suction on the wall, you guys ever notice the numbers on there? It's going to give you some numbers. So it'll start out like 50, and it'll say 100, and then like 150, so you can look on there. I recommend you get your little Sharpie, and you mark on there. They first come to you from recovery. Okay, you're the SICU nurse, they come to you, and you get it, and you mark on there. Let's say they came to you at 9 o'clock in the morning. You mark on that suction canister, when you hook it up to suction, whatever kind of comes out then, you mark on there 0900 in your day, okay? And then, an hour later, when you go back in there, look at it. If there's not really any change, don't worry about marking it. But let's say they put out another 100. You mark it and put your time. Why would I do that every time I went in there? So I can actually see, same thing with chest tubes. When you got a patient with a chest tube, I always mark a day and a time when I look at that chest tube. So that when I go back and look at it 4 hours later, I know what it was. Or I can even look back and see what the nurse marked at 12 hours ago. Does that make sense? So you can physically see, because in that way you're not having to go dig around in a chart and hope somebody documented something. Or they may have changed out the canister, and then guess what? Now you don't even know what they did, okay? So on the suction canisters on the wall, there's numbers, and you can actually mark that so you can keep up with how much that is.
So how much is too much, 200, is that like the?
Okay, let me put it to you this way. How many mils do you think is in 1 unit of blood? 1 unit of blood.
1,000?
250. 250 is in a unit of blood, okay? How many units of blood? Oh, you were supposed to look up something for me earlier. I'm thinking about that now. You didn't do your assignment.
No, I didn't do it.
You did, okay, we were talking about hypoglycemia in diabetic patients related to what? Did you look it up?
Yes, I did, proton pump inhibitor.
Proton pump inhibitor, diabetic patients are at risk for hypoglycemia because
Because it can raise serum gastric concentration, and therefore it affects glucose metabolism and enhances insulin secretion.
so it will increase the amount of insulin and decrease the amount of glucose secretion. There you go. Look at there. Little research, little Google work for you. I like it, okay?
That doesn't help.
Okay, all right.
It lowers the
Nobody
blood
remembers
sugar
anything, they're gonna
by
remember.
lowering the blood
Got it.
sugar.
Hypoglycemia,
That's
diabetic
one.
patients, proton pump inhibitors, right? Okay, gotcha. So, yes, so 250 mils is actually 1 unit of blood, okay? So let me ask you this, okay? How would you know, because there's no magic number. There's no magic number. If my patient come back to me in an hour, they only put out 50, and then another hour later, they went in there and they only put out 50, okay? And then another hour later, they're not losing that much. But how do I know if my patient's tolerating that?
Oh, there's their body.
How do you know your patient, how do you know too much output is too much, that your patient's hemorrhaging? Is it going to be a magical number? No. How do you know?
Look at your patient.
Your assessment, right? When I open the door and I go, they look like crap, right? Sign number 1, okay? Number 2, you go over there and you check your vital signs and your heart rate is 160 and your blood pressure is 90/40. Is that sign number 2, right? Okay? Skin is pale and clammy. Sign number 3, right? But let's say that my patient, let's say it's been 4 hours. 4 hours and they put out 200. You know, that's 50 an hour. But let's say my patient's alert, my patient's oriented, their skin is warm and dry, there may be a little tachycardia, maybe 110, 115, blood pressure's good, respiratory rate's good, Is my patient tolerating everything good? It's on assessment. The reason I don't want you to get fixated on numbers is because that is a lot of times what I see with newer nurses is they'll go, I'll call the doc when they lose about 500. You see what I'm saying? But your patient may not tolerate losing a bunch. So it all is going to depend on your patient. There's not a magic number. I want you to look at the patient assessment as a whole and go, do I need to do something or not? Yes.
So what would be the first signs and symptoms that we gave the wrong blood? For example,
Oh, you are going to learn that in hematology. You're talking about reaction. Well, you're going to see some anaphylactic reaction if you gave the wrong blood. But yeah, we don't have time to go off in there, but yes, you're going to learn all about that in hematology. You're going to learn all about blood transfusion in hematology, okay? All right, let's move on with this. We can kind of get done with this before we go home. All right, and so we're monitoring this bloody drainage. It's okay to have it first. Then it's going to switch to greenish yellow, which means that it's what? Some bile being produced in there. That's normal, right? Okay. I talked about in all of these post-surgery patients, right? We want to cough, turn deep, breathe every 2 hours and send a spirometry because I don't want pneumonia setting in. Keep these patients in that that 30, 45 degrees or higher. Okay, when they do get to start eating one day, sit them straight up. Sit them straight up when they do get to start eating. You remember, you already kind of went in there and jacked this esophagus. They need all the wall gravity that they can, so sit them straight up, okay? These patients actually need to sit up for 2 hours after they eat when they get to start back eating, okay? That gives that extra time for everything to go down and digest, okay? All right, oh, that was only just one more slide. Okay, we're going to stop right here.